Hey everyone, my name is Debraj Shom, and thank you once again for joining one of the main webinars for global cosmetic surgery, and this is called Aesthetic Talks. I'm going to share my screen shortly. Just give me 1 minute, please. So as some of you may be aware, and many of you may have actually attended our meetings, global cosmetic surgery came up between 2020 and 2021 when the pandemic was in full flow. And what really started out as webinars to try and keep us all engaged ultimately became a learning platform for aesthetic medicine specialists all over the world. After the pandemic came to an end in 2022, the highlight was when the American Academy of Cosmetic Surgery, or the AACS, decided to tie up with GCS to create an event called the Deep Dive in 2022. And 2023, we took a break. Before 2022, some of our meetings had actually garnered more than 3,000 delegates all across the world, each one of them. And the largest number of countries covered at one point was 44 countries in one of the webinars. Now, in 2024, we started off with the hair talks, which was on the 18th of August. Dr. Michael Gold was the preceptor and moderator of the same, and Dr. Jane Yu gave us the keynote address. On 8th September, which is today, we start off with the aesthetic talks. The 22nd of September, which is going to be shortly, 2 weeks from now, is another hair talks, and I shall talk about that shortly as well. Today, it is a privilege to be speaking on surgical and non-surgical eyelid rejuvenation. The eyelids are different from any other thing anywhere else on the body. The eyelids are extremely delicate structures, and so from that perspective, we need specialists in treating the eyelids. It is a great privilege and an absolute honor to be seeing some of the specialists who are here today. They've taken the time to be with us, and 900 delegates have registered from over 26 countries. Some of our faculty comes in from areas like the Pacific Standard Time, like in California, such that it's early in the morning. And many of our faculties will be past midnight in their local times when this all comes to an end. And all of this because global cosmetic surgery truly believes that everyone deserves to learn from the best. Now at Aesthetic Talks, this is Debraj Shom, and I'm introducing you to Aesthetic Talks. After this, I'll hand over to my partner in crime, Dr. Tanuj Nakra from Austin, Texas, who will introduce the topic and the speakers and the main keynote speakers. Then we have two of those folks who people would easily pay to listen to. Guy Massry has literally treated every eyelid which is worth treating on the west coast of the US. And Wendy Lee, again, is a superstar in terms of everything that has to do with eyelid rejuvenation. Then we have a panel which is absolutely stellar, consisting of some of the leaders, topmost leaders from the UK and the Asia Pacific region. And then finally, we end all of this with the audience questions, which will be a chance for all of you to ask various questions to our distinguished panel. Once again, thank you all for being here today. And it's been an absolute pleasure to put this together for all of you. And I hope you have great learning, just as we hope to do. Not to forget, one more reminder, on the 22nd of September is the next Hair Talks, and you can register for that shortly. And we have one of the top keynote speakers for that as well, as we try to explore female pattern hair loss and treatments for the same. Over to my partner in crime, Dr. Tanuj Nakra, who is also one of my best buddies. So over to you, buddy, to take things over.
Thank you, Debraj. Wonderful introduction to our first aesthetics talks, which is going to be a recurring series of lectures spanning the field of oculoplastics, cosmetics, and facial cosmetic surgery. And so we are very, very honored to have Dr. Guy Massry and Dr. Wendy Lee here with us today. I'm going to start by introducing Dr. Massry, and then he will give us a wonderful lecture on lower blepharoplasty. He'll be covering both primary blepharoplasty and revisional techniques, and we can't wait to hear from him. Dr. Guy Massry is one of those people that really doesn't need an introduction, but I'm going to go ahead and make sure everybody knows all his details of his biography. He was born in Southern California. He went to University of Southern California for his undergraduate degree and his medical school education. He traveled to St. Louis University for his ophthalmology residency, where he learned to like St. Louis style pizza and toasted ravioli. That's where I'm from, St. Louis, and so I was very proud to know that he spent some time in St. Louis. Then he went to Manhattan, Eye and Ear in New York City for his fellowship and his Aesopers Fellowship in oculoplastic surgery, and then returned back to St. Louis University, where he was a professor on the faculty of the Anheuser-Busch Eye Institute. He then moved to his home again in Southern California, where he's been in private practice for the last couple of decades. His list of accomplishments is immense. I'm sure one of his proudest achievements is training fellows. He's currently a co-fellowship director with Dr. Ray Douglas for an Aesopers Fellowship. He's also a co-director with Babak Azizadeh and Paul Nassif, names that everybody knows, for an American Academy of Facial Plastic and Reconstructive Surgery Fellowship. His honors are numerous. I can't spend too much time because otherwise we would limit his talk, but some highlights are that he's on the editorial boards of the Aesopers Journal, Aesthetic Plastic Surgery Journal, the Facial Plastic Surgery Journal. He has garnered numerous teaching awards. He received the Aesopers Bayless Cosmetic Surgery Award, hundreds of publications and book chapters and textbooks that we've all had the pleasure of reading. And personally, Guy, you may not remember this, but I was a lowly resident when I attended one of your Bright Eye sessions at an AAO about 20 years ago. And I remember you even then, as you are now, as a kind, energetic, enthusiastic teacher. We're very much looking forward to hearing you speak today. Thanks, and we'll hand it over to you, Guy.
Thank you so much. Let me share the screen. Okay, slideshow at the beginning. All right. So when I first spoke to Tanuja about topics, I was going to talk about brow lifting and lower blepharoplasty, and we decided and settled on lower blepharoplasty. What I'm going to do is talk about my experience over the years on lower blepharoplasty and transposition, because the actual procedure has evolved in many, many ways. And I've kind of broken it down into its basics. I'll just show some surgical photos, pearls, video presentation. And then for those who know me, I always have these timely digressions where I kind of interject some opinions, and we'll do that also. So the goal of surgery is pretty simplistic. It is to reduce the fat prominence, but preserve and transpose that prominence, which is the fat, to the hollow below to smooth the lower cheek interface. This effaces periorbital hollows and gets rid of the bag. So it treats the lower lids, the hollows, and the midface, the transition from the lower lid to the midface as one aesthetic unit. And as all my fellows know, I harp on this. The goal is to create the CC of youth, or the concavity convexity. This is pictures sent to me by the patient. Sorry about that, they don't match in color. This is a convexity, concavity, convexity, which is the typical aging change you see in the lower lid from fat prominence. And this is the concavity convexity. So by using this fat as a substrate and transpose it to the hollow below, you can get this kind of transition. The goal is to always create the CC of youth. Doesn't matter how you do it, that's the goal of creating youthful eyelid. Another example, what I call a double bubble, convexity, concavity, convexity, CC of youth. And how do you do this? Well, the best candidate is one that has fat prominence, ample substrate to transpose, an adjacent hollow, a non-tight lower lid. This will be a digression. I'll talk about it later. I think our next evolution here is understanding what tight lower lids do to this surgery. It's simpler if you transpose fat to the tear trough, the nasojugal groove. That's what's been studied the most. There's been very little study on transposing in this area, but the lateral hollows can be effaced. And then you can excise skin, tighten the lid, inject fat, do mid-face surgery. These are all adjuncts added to synergistically, I want to emphasize that, synergistically enhance a recreation of that concavity convexity. So it all starts with fat access, and you have two options. So sorry. You could access fat preseptally between the orbicularis and the septum. That means you're making an incision between the fused eyelid retractors and septum. You can enter fat this way, or you can enter fat this way post-septally. There's no difference in aesthetic outcome. We've studied this, published on this. More important is that there's no incidence of eyelid malposition. The dogma in our literature and in aesthetic medicine has been that a middle lamellar scar, in other words, violation of the septum, can lead to eyelid retraction. That is not the case. It's been changed. It's been changed in the literature too. It requires a skin, muscle, septal incision, a multilamellar scar to get eyelid retraction. And the only way to identify if the septum is a culprit is to isolate in transconjunctival blepharoplasty violation and non-violation of the septum. So that's actually a fallacy in the literature, and we've shown that's not true. This slide really eloquently and delicately shows the complex lower lid anatomy. And it explains pre versus post septal entry to fat. Shown is the septum right here, the retractors, and then the fused septum and retractors. So you could either go preseptally between orbicularis and septum to enter fat. You can go retroseptally, and you can see when you hold the septum and retractors, the fat's in between. I don't do this routinely, but when I do eyelid retraction cases, I recess the retractor so you can see this. This video will describe it.
So this is the edge of the conjunctiva. This is the conjunctiva over the cornea and over the sclera. And then this right here is the recessed retractors. So to go through retractors, you go this way. If you did a transconj bleph, you'd go through conj and retractors. This is retroseptal to enter the fat. Here's for old septum. To get fat preseptally, you go this way. How do we know that's true? If I look between the retractors and the septum, you can see the fat, which is embodied between the two. This is really nice anatomy. So, conj over cornea over sclera. Fusion of septum of retractors, usually 5 millimeters below the tarsus. Retractors, septum, fat in between.
That shows the anatomy nicely. Now, my preference is to enter retroseptally. And I don't like doing this with an assistant. We use this technique called the GRED, globe retrorepulsion eyelid depression maneuver. So you use 2 fingers of one hand. Because the orbit is bone and is rigid and the internal contents aren't, if you press on the globe and depress the lid, fat will come forward. And so we use that. And just by titrating your fingers, you can access the area that you want to go. Where do you make the incision? Well, the literature was never clear on this. So we did a study with a colleague of mine. Wow, he's now in Philadelphia, Cesar Briseño. I'll give him a shout out. And we found that if you made an incision 6.5 millimeters below the tarsus, you would enter fat 82% of the time. And traditionally, it had said make the incision 3 to 5 millimeters inferior to the tarsus. At the arcade, it was all ill-defined. We defined this, and this is pretty consistent. And with the incision at that level, the incidence of chemosis was not larger than in other studies in the literature. So this is the GRED.
GRED maneuver below the retrorepulsion eyelid depression, and I'm going to make an incision about 6.5 millimeters below the tarsus, and you'll see that the conjunctiva retractors are cut, and the fat comes forward, and we enter the retroseptal space.
It is very predictable, easy to do. I then use a traction suture to engage both the conjunctiva and retractors. If you just engage the conjunctiva, you'll tear it, it'll cheese wire. I secure it to a head drape. Not in this photo, but I'll put a piece of gauze between the traction suture and the skin. You can get a depression that lasts even a week if you don't do that. And this gives you exposure, eye protection. It rotates the fat forward. My favorite instrument's a Q-tip. I dissect retroseptally to the orbital rim. You'll expose the fat pads and the oblique. The oblique is deep. We'll talk about that in the next slide.
Now I use a blunt Q-tip to get to the retroseptal space. And what I will do is extend the incision to the caruncle and laterally to give myself more exposure. And you can see when I separate the fat pads that the oblique muscles in between them. I'll show that better in a second.
So the separators of the fat pad. The oblique separates the nasal and central fat pad. The arcuate expansion separates the central and lateral fat pad. The oblique is deep. It originates on the floor of the maxilla, inserts on the sclera behind the macula. It's deep. So these fat pads override each other. They appear as one. You have to separate them from the oblique. The expansion is very superficial. Why is that important? Because if you have a patient look up as a clinical pearl, because these fat pads right over the oblique, they look as one. When you look up, you rotate the fat forward. That's why I have them look up. But you can see where the arcuate expansion is laterally separating the central from the lateral fat pad. It kind of lets you make that assessment beforehand. You then want to create your flaps. You want to free the fat from the inferior oblique, the caruncle, and the orbital rim. This fat is continuous. In the upper lid, the nasal fat pad is continuous with orbital fat. This preaponeurotic fat pad is not. They're separate fat pads. They look different, have different color, have different biochemical characteristics. In the lower lid, they're continuous, so you can slide them underneath each other. And if you do that, we call this the inverse shoe shine sign, because it's like shining a shoe, this being the shoe from underneath. It tells you that you've released all the connective tissue attachments to muscle. Leo Corneef showed that the ocular motility system consists of attachment between muscle, connective tissue, and fat. So you can restrict movement without touching the muscle if you don't break those connective tissue attachments.
Okay, so we've opened up the retroseptal space. This is the nasal fat pad, quite robust. This is the central fat pad. They've been freed from the oblique muscle. They move freely underneath. I called this the inverse shoe shine sign. Is this critical? I don't think it's critical, but it helps me know that the fat is released from the muscle. This is the caruncle. This is the infraorbital rim. Your two fat pads. These will be put together as an omentum and repositioned into the hollow.
Okay. Now, do you transpose the fat supra or subperiosteally? No one knew. For years, we talked about the procedure. No one knew about it. 2 papers. I wrote one with a colleague in Israel. He transposed fat above the periosteum. I did below, but we also plicated the orbicularis. So they were confounding variables of 2 surgeons in 2 locations, and also tightening the orbicularis muscle. But we showed that there was no difference in outcome. I then did a study with a fellow where I transposed both sub and supraperiosteal. Again, we found no aesthetic difference. There is a difference in recovery. I think there's other differences, but aesthetically, it doesn't make a difference which way you do it. I have certain preferences, but it's a long discussion. Maybe in the Q&A, we can talk about that. The subperiosteal dissection, I like using a caudal, not a Freer elevator. I like its sharp ends. I dissect around the infraorbital neurovascular bundle, all the way to the piriform aperture, the side of the nose. The periosteum in that area is very indistinct. When you transpose the fat, you actually get a little orbicularis elevation or mid-facelift. I'll show you that in a video. And again, care with tight lids, we'll get back to that. That's a new concept.
This is the nasal fat, the central fat, the oblique in between. The white is the arcus marginalis. I'm going to cut right through it to the orbital rim. And when I cut through that, what I'm reducing is I'm releasing the tear trough ligament. The tear trough ligament is where the eyelid, palpebral orbicularis, meets the orbital orbicularis. And you can see we're now down to periosteum. When I elevate beneath, I'll be elevating the levator labii superioris. The infraorbital nerve is below that. Okay, I'm starting my subperiosteal dissection. I'm going to elevate the levator labii muscle below the periosteum. We're getting a little blood there. It's not unusual. And you can see I'm down to periosteum here. And the dissection can go all the way down to the piriform aperture. So here's your bone. Periosteum's above you. It's a little bloody.
Move on there. Okay, how does anatomy guide us? This is an important slide for understanding. So when you're doing this dissection, the first thing you cut is the arcus marginalis, a white structured periosteum where the periosteum of the orbital floor meets the maxilla. Then you release the tear trough ligament. Brian Mendelsohn from Australia, Melbourne, a great anatomic plastic surgeon, described this. It's where the eyelid, preseptal orbicularis meets the orbital orbicularis. You can see it here. That'll be the first thing you release. When you get below the tear trough ligament, the next structure you'll see is the levator labii superioris muscle, which is here and which is here. The aliquinasi is here. The levator labii superioris aliquinasi is the longest named muscle in the body. So for short, people call it the Elvis muscle because it perks up that portion of the lid. So we just call it the Elvis muscle. Underneath the levator labii is the infraorbital neurovascular bundle, then the levator anguli ori, one of the 11 muscles that attaches to the lip. This attaches to the modiolus, and the fat is transposed here. You have to know this anatomy. The infraorbital nerve, I think it's important to understand. Here's a picture of it during a dissection. At the end, I'll show you a full video narrated with this nerve. But the infraorbital nerve originates from the brain. It's cranial, from V2, the trigeminal nerve. And it comes off the maxillary branch, the second branch of V2. And it never actually enters the orbit. It exits the cranium from the foramen rotundum, if you remember from your anatomy in school, and it goes through a canal, groove, and foramen of the same name, and then it exits in this area and innervates the lower lip, cheek, side of the tip of the nose, and the gingivobuccal sulcus, and it traverses with the infraorbital artery, which is not cranial in origin. They do come together. So here's the trigeminal ganglion. It's called the Gasserian ganglion. It sits in a buccal crevice called Meckel's cave. This is V1, which we're not talking about. It enters the orbit through superior orbital fissure. This is V2 that we are talking about. You can see it's below the orbit. It sends branches, the zygomatic branches, into the orbit, but here's where it exits. The artery is very different. The artery originates from facial soft tissue. The external carotid has 2 terminal branches. The first one, the internal maxillary, its terminal branch is the infraorbital, and then the superficial temporal. Why is that important? Because if you inject fillers in the tear trough area, if you got into the infraorbital, to get blindness is a 1 in a gazillion, because you'd have to go retrograde this way, communicating branch up to get to the ophthalmic. If you go more nasal, you can get the dorsal nasal artery, but that's why tear trough injections are so incredibly rare to get blindness. It's all about anatomy. Okay, back to the surgery. We now create our fat flaps. You can do them individually or combine them together. These are individually transposed. I now combine them together as an omentum around the infraorbital nerve. You could secure them internally or externally. There's been no studies comparing the two, but there have been studies using fibrin glue. Why do they do that? Because the sutures, whether externalized or internalized, can lead to bleeding sometimes, and this has been shown to maybe reduce bruising and swelling. When you transpose them, you don't want to tie the suture too tight. You'll kink the flap over the orbital rim. It can become ischemic and get nodules. If you do it too loose, it can retract. Some doctors tell their patients after surgery not to make rapid upward eye gaze movements for a few weeks. I'm not sure it makes a difference.
So this is the needle going transcutaneous into the wound. I'm going to grab it, pull it out. My assistant takes tension off the lid, This is the fat pedicle, nasal, I'll grasp it, central, I'll grasp it, and I'll go to and fro.
And then you just go the other way to transpose it through. I'll show you in the end a full video, so we'll kind of cut out here. Okay, the fill effect. Is it just fat that you're transposing, or does orbicularis come up too? It's been published. John Holds years ago published through something called a dipstick test that the orbicularis comes up too. And you'll see when you transpose externally, because the periosteum's so indistinct here, that the midface actually comes up a little bit too. Now, does it work? It wasn't until 2016 that any study showed that this actually works. We talked about it without any evidence-based information. And a friend of mine in California, Tim Miller, who's a facial plastic surgeon, did a study with 3D cameras and showed that at a year, you got a 0.7 millimeter increase in volume at 1 year. MRI studies out of Asia have now shown that the fat actually fills that void too. So we actually know it works. And these are just some examples of recreating the CC of youth. This is just transposition. From here to here, here to here, just transposition. It's a very consistent procedure. And you can transpose all the fat pads. So in every case, that concavity, convexity is created into a concavity, convexity. And this is men. In these men, I usually will do a canthal suspension, take out some skin. So this is not isolated transposition. And if you look, the oblique views show it best. You can see the transition, how much you've improved it. Again, very consistent procedure. Some helpful hints. What about the lateral hollow, the orbitomalar groove? Traditionally, it's thought you shouldn't transpose this. It's more fibrous. There's not enough. It retracts. I have no idea where this came from. It's completely anecdotal. You can do it. I do it all the time. There's a suggested higher risk of diplopia. It's interesting. It's never been published or shown. It's just an anecdotal suggestion. I don't think it happens, but you can do forced ductions. Should you cut the arcuate expansion if you're transposing the lateral fat pad to make them continuous? I have never seen the globe drop or any change in position from doing this. So it's okay to do it. I don't, but it's certainly okay to do it. I'm a very anatomic surgeon, so I don't do it. Really important, watch for a thick pretarsal orbicularis muscle. If it's present beforehand, it's going to be much more obvious afterwards. If you tell patients beforehand, then afterwards they expect it. If you don't, it's a surgical error. This is really hard to mask with filler, so just tell patients beforehand. This is a complaint I see from post-ops sent to me all the time, where they notice another eyelid bag, which they feel they didn't have before. It's very common in Asians, Afro-Americans, and Hispanics. And just one more example. Is there enough fat? So this is important. I asked 5 surgeons on this patient if they felt they could transpose fat. All said no. But this is a young patient, and I felt differently because what I've noticed is their orbital septum is very thick. If you have them look up and fat comes forward, you can transpose. I firmly believe that release of the tear trough ligament, even if you put nothing underneath and just elevated a little bit with a transposition suture, even if it's just a little bit of fat, that they'll have an improvement. Now, I believed this for years, and I would talk about it, and everyone said, you can't transpose fat. You don't have enough substrate. These are some examples, but fortunately, this paper was just published. I think it's PRS. Transconjunctival fat repositioning, is excess fat a prerequisite? And their conclusion was it's not. Now, this was in a Southeast Asian population, but what they found was if you release the ligament and put almost anything underneath, just transpose a little fat or just some free fat pearls, that you would get an improvement. This is a new concept, which we're publishing on now, called an anteriorly projected rim, APR. So if you have patients where the orbital rim projects forward, it goes this way, and you transpose fat over it, you're going to make it more prominent, and they'll have they'll have a protuberance in that area. So this is done by palpation. You can't see it. But if this is projected forward rather than transposing fat, I'll excise it and I'll graft below. This is an example of an anteriorly projected rim, where the rim here is anteriorly projected. It's really hard to see on a picture. It's something done by palpation and feel, but we have a large series of patients I've seen that have had this done to show that if the rim is anteriorly projected, you can get a little bit of a bulge there, so to try something different. Another new concept, which we're about to publish, is TIIS, tarsal ischemic / inflammatory syndrome. Let me go over this because this is important. We've had over 40 people referred to me, and I've had a few of my own in which I went into the midface transconjunctivally, where they developed postoperative cicatricial changes of the posterior lamella. And they've developed entropion, retraction, dystichiasis, and trichiasis. And we try to figure out why. Well, the commonalities were they were all very, very tight lids, very tight lids. None of them all of them used an insulated retractor. So it's not a burn from using the electrocautery unit. I believe it's from too much traction on the lid, on a tight lid. And the mechanical traction can kink the marginal arcade and get ischemia or microfracture the tarsus. So on these tight lids, either release the canthus or do it in such a way where you're not pulling too hard, because the risk, what you see at the end of the case, is posterior tarsal conjunctival petechia. And if you see them, it takes about a month for these findings to show up. This is an example of an entropion, which we had to repair. She needed a palate graft. This is a woman that came from South America to see me that had this TIIS, this ischemic syndrome here, and lumps and bumps from fat grafting. I'll touch on how I address that in a minute. Okay, so we looked at the last almost 400 patients that had isolated repositioning only at an average follow-up of 13 months, and their satisfaction rate was 96%. There wasn't a previous satisfaction study. I think Brian Leatherborough might have in the UK a number of years ago, but he transposed it above the periosteum. But his satisfaction was just as high. So we know it works, and we know there's high satisfaction. What else do we know? Evidence-based. It works, high satisfaction. You can go below or above the periosteum. Pre or post septal doesn't make a difference. We just don't know if external or internal fixation is the answer. What about diplopia? I get called by surgeons all the time saying, hey, there's some diplopia after surgery. Well, immediately post-op, it's usually anesthetic because the anesthetic hits the pupiloconstrictor fibers, and you can get a dilated pupil. It's usually oblong. Swelling, diplopia hit the muscle. It's usually temporary. Swelling, it's rare to get double vision beyond a short period of time for swelling. I've seen it up to 2 weeks. If you put compressive tape on the lower lid, it pushes on the globe. It may be a little bit higher, but that goes away. Injury to the inferior oblique muscle. This is very, very rare. The inferior oblique is an elevator. It's an elevator, excyclotortor, and abductor. The eye will be lower. The image will be higher. It always is binocular diplopia and vertical. So steroids, oral injections help. They almost always resolve. If I think it's an oblique injury, I do not go in immediately unless they have diplopia and primary gaze. Because if it's a traumatized muscle and you go in surgically, they'll traumatize it even more. So if they're in primary gaze and it's restricted, I'll go in. And it's very rare. I've only seen it a few times. On the other hand, if they have it in a different gaze position, I will wait it out and treat it conservatively. Almost all go away. Myself have had one case that took a little over 1.5 years. It was an extreme down gaze, but it did go away. Also, if they have diplopia, always did they have an upper blepharoplasty too, because double vision is exponentially higher after upper blepharoplasty from a superior oblique injury when you're manipulating the nasal fat pad, much more common than in lower blepharoplasty. Dilated pupil. Sorry, I confused this with the last slide. So when you're injecting anesthetic into the inferior orbit for the surgery, you can get dilation of the pupil by hitting the pupiloconstrictor fibers. It's usually oblong. But when people are doing this surgery and injecting fat, they worry when they get a dilated pupil if it could be embolization of the central retinal artery. So there's a simple way to figure it out. Just turn the lights off in the room, shine a light into the dilated pupil, and if the sensory system is working, the other side will constrict. If it doesn't, that's a problem. But I've never had someone call me worrying about this and told them this and found out that it was an afferent issue. It's always pharmacologic from hitting the fibers of the constrictor muscle. TXA, this has really changed things in many ways. It's a lysine analog, and it binds to a receptor on plasminogen, inhibits the conversion of plasminogen to plasmin. You don't break down fibrin, so you get less bleeding. Now, for facelifts or skin grafts, I wouldn't use it. There's been studies that have shown that the dermal plexus gets ischemic and you can get necrotic events. But when you're doing it for lower blepharoplasty, that has not been the case, or endobrow lifting, because it's a thicker flap, just not subcutaneous. You can do it locally and mix it with some lidocaine. You can give it IV. You have to give it slowly because it could affect blood pressure. I don't use it topically. What about transposition nodules? They're common for 6 to 8 weeks. It's usually relative ischemia from the flap going over the rim, causes inflammation, very rare to get infection. They go away 95% of the time on their own with massage, injections. Orally, you can use minocycline, which has been used to treat inflammation in medicine for years, rheumatoid arthritis, etc. Singulair, which is montelukast, it's a asthma medication, is used by plastic surgeons for capsular contraction with breast surgery. We've used it in this situation too, and it's helped. I've only had to excise very few of these that did not go away. Pearls on transposing is if you tie the suture too tight, you can get a nodule. If you tie it too loose, it could retract. But if you've released all the connective tissue attachment, that shoe shine sign, that shouldn't happen. If it does retract, do not repo it again, cut it out, because it's going to be fibrotic. It doesn't work as well. Chemosis, these are all the reasons in literature. You're all familiar with them. How do you treat it? What I do that almost prevents it 100% of the time is I put a little inner marginal suture. I use a 5-ochromic from the lateral upper to lower lid. And every time they open their eye, it pulls the lower lid up and compresses it. And I find that that really reduces the incidence significantly. You can also compress with your finger, lubrication, topical steroids. I find that hot point cautery, putting some tetracaine in the eye, if it's persistent, a little local under the conj, and use a high temp hot point cautery and just scatter little burns. It causes the conj to scar down through tenons to sclera, and it makes it go away very quickly. What about post-op edema? You can use the regular treatment, steroids, jade roller, but this is the most important part of the slide. You want to re-examine the filler history because in today's day and age, 95% of the time, that's the culprit. Pre-op filler patients, even with a remote history of fillers and hyaluronidase, intraoperatively we see engorged vascular fat, more fibrotic fat. Filler is bioactive, even if it's not a biostimulator. It's very much like thyroid patients. We have some really nice pathology specimens. Post-operative, we see prolonged edema, indurated fat flaps, nodules, and protracted recovery. So anyone with a lower lid or mid-face filler history, even with sessions of hyaluronidase, is at high risk of unhappiness and complications. I tell that to patients. Out here in California, it's endemic and almost an epidemic, but filler makes surgery much more complicated. Some examples. This is a woman that had some surgery on her lower lids. She'd had fillers 4 years prior to the lower lid and mid-face. No issues. The history was not obtained. She had surgery in 3 weeks. She presented like this. These are hard rocks. If you touch them, they feel like a stone. She was healthy, no illnesses, no vaccine. Why do I say that? Vaccines, we learned during COVID, can stimulate immune reactions in the filler. Some of the epitopes are similar. Flu can do it. Teeth cleaning can do it. I have patients that have filler, that I put filler in. If they clean their teeth, I tell them this can happen and you may want to prophylax with antibiotics. I've seen it at least 20 times. So how do you treat these antibiotics? Steroids, mild improvements, 5-FU helps a little bit. This is the new one, mycophenolate, Cellcept. It makes a huge difference, and I'll talk about it. This is after aggressive mycophenolate. It wouldn't go away, and then I did surgery on her, or she's soon to have surgery to clean this up. This is a gentleman who was immune deficient a little bit beforehand for various reasons, but he had filler, hyaluronic acid filler 15 years ago to the midface. He had someone did a transconj bleph with transposition, and this happened, and I could not make him better with anything. So now he's actually seeing rheumatology and is on cytotoxic agents, cyclosporin, methotrexate, etc. So what is mycophenolate? Mycophenolic acid. It's an immunosuppressive agent. It stimulates your natural T killer cells, and that's how it inhibits organ rejection in kidney, liver, and heart. It's also called Myfortic, Cellcept. You have to check the white count beforehand. It could lower it, but I use a very low dose, 250 twice a day for 3 weeks. The immunosuppressive doses for cancer, as you can see, are much higher. It works for these inflammatory nodules really, really well, and it is not a dangerous drug to use at these levels, but it's kind of a game changer and something to turn to in these situations. Now, you can also add fat grafting to repositioning to further augment fat. I do the fat grafting first above the periosteum. I transpose below. If I transposed first, when I injected fat deep, it would go into an open space. I don't put local over the subrim, as I normally do if I'm grafting fat too, because the local at 1 or 2% is toxic to the grafted fat. That's why one of the reasons that we use tumescent anesthesia, and these are examples of transposition with grafting. So it's adding more to get the hollow effaced, and just another example. Now, fat grafting, a few words on that. Everyone fat grafts and talks about how benign it is. Well, I can tell you it's not benign because we just published this paper. We call it the management of lumps, bumps, and contour irregularities after grafting fat to the lower lid. And we have a large series of patients sent to me that get these kind of changes. These are discrete nodules. You can get diffuse enlargement. You can get multiple nodules or a mixed picture. And if you look at the surgical drawing, this is fat behind the septum, normal native eyelid fat. The fat that's grafted is always, we have found it 100% within the orbicularis muscle. So you have to fillet open the orbicularis muscle to get it. It's a little bit of a tricky surgery. So if you do fat grafting well, it's safe, but you can get lumps and bumps, and you need to be aware of that. And the fat looks very different, as you can see. This is grafted fat. The other problem we've seen from fat grafting is people that had fat grafting, and then they had practitioners inject it with 5-FU, steroid, Kybella, used Ulthera, microfocus ultrasounds, and they get different kinds of hollows. They get this geographic hollows. So let me go back here for a second. These are traditional periorbital hollows. They're consistent from patient to patient. They're age-related. We call them primary periorbital hollows. I call these secondary periorbital hollows. They're geographic, larger, and they're deeper from peak to trough. So we've used what we call dermal onlay grafts. These are dermis fat grafts, dermis side up, fat down, to help treat these. So dog procedures, so you can use these to treat it. Now, in my practice, I'm not going heavy into revisions because the talk was really on transposition. The majority of revisions I see are due to fillers. By and large today, I see at least 5 or 6 of these a week, edema, dyschromia, nodules. Surgically, from blepharoplasty to upper blepharoplasty, ptosis repair about 50%, lower lid retraction, fat grafting, nodules about 40%, and canthal issues are about 10%. So I'm going to end with a full video on this. I'll tell you a funny story. I had a medical student actually come out and see me from the Dominican. I usually don't take medical students, but his preceptor was a friend of mine, never been in the OR, didn't know anything about surgery, and asked me, can I video this case? I said, sure, just don't show the patient's face. A week later, when he got home, he sent me this video with captions, with pictures from my textbook. It's the best video I've ever seen on this procedure. And I asked him, that was really nice. Why'd you do this? He goes, I want you to invite me back. So I offered him a year, and I'm actually giving him housing too. And he's coming out and spending a year for me. So job well done, and you get rewarded. This is the full video. A medical student did this for me. Crazy. Oblique.
Dr. Massry, as this video is playing, can I give you a quick compliment?
If I have to.
One of the side effects of your presentation and showing your mastery is that you're going to have surgeons from around the world wanting to visit you so that you can do their eyes.
Yeah, that's happened. There's the infraorbital. It's a really nice example of it. I was blown away. A medical student did this. That's the tear trough ligament where the orbicularis of the orbit and the lid meet. There are those that say it doesn't exist. It does. Don't tell Brian Mendelsohn it doesn't exist. It's almost done, guys.
No worries, we're great.
So you can see the fat pads in the oblique. They act as an omentum. And that
I know.
tear trough ligament no longer indents the skin because you've cushioned below it. There you go. Thank you so much.
I know we have a panel discussion, but may I ask you one question before we move to the next speaker?
Yes, sir.
In your opinion, does it make a difference whether the two pedicles, the medial and the lateral fat pads, go separately or they get joined together like you did in the video?
That's a good question. I don't think it makes a difference. I used to individually transpose them and the effacement was still smooth. It just saves me a step to put them together rather than doing two at once. And you only have to take one transposition suture out.
But even if there's a lateral hollow, it wouldn't make a difference if
So
you combine the
hollows-
two versus took them separately?
So a lateral hollow is different. When I transpose laterally and I transpose centrally too, there can be a little gap between the fat internally. What I usually do if I see that gap, you have two options. You can take the lateral pedicle, and if you cut it at its base, the fat will slide over. It just naturally expands there, or you can put a suture internally between the two of them.
Thank you very much.
But I also
Well,
wanted to say that when you tie these transposition sutures externally, you don't get a prolonged elevation of the midface, but the orbicularis comes up. And when it does, that helps efface the trough too.
Thanks.
Well,
Thank you.
thank you, Dr. Massry. That was a masterful lecture on transposition lower blepharoplasty. I think in 2024, only you could have given that lecture, and we're honored to have been able to have you join us today. We're definitely going to have a chance to have conversations with Dr. Massry later after we hear from Dr. Lee. We'll have an extended session of Q&A and commentary from the panelists. Speaking of the panelists, I just want to take one moment to spotlight some of the international superstars that are here with us that will be leading our discussion session later. So all the panelists and our fellows, please turn your video on so you can wave when I call your name. First, we have Dr. Daniel Ezra from the UK, who's joined us today. Thank you for joining us. Dr. Dongmei Li from Beijing, China. Thank you very much for joining us. Jocelyn Cohn from Chile. Also one of my alumni co-fellows from UCLA. It's always wonderful to have you. Kyungyin Woo from Korea at Samsung Center. Kasturi Bhattacharjee from India. Reynaldo Javate from the Philippines. And we have Yunia Irawati from Indonesia. And then we have some of our wonderful fellows here as well. We have Dr. Mikhail McCoskey and Dr. Kendall Goodyear, who are helping behind the scenes. So thank you all for joining us. We're going to be looking forward to hearing from you. These are all true international superstars, leaders in the oculoplastic surgery societies in their regions of the world and internationally. Thank you all for being here. So next, I'd like to introduce Dr. Wendy Lee, also someone who really doesn't need much of an introduction. As many of you know, she is the incoming president for the American Society of Ophthalmic, Plastic, and Reconstructive Surgery. But let's give you a little background on Dr. Lee so you get to know her a little more. So she went to UCSB for undergraduate, and if you haven't been there, it's one of the most beautiful campuses in the world. Then she got a master's in Georgetown, because why get just an MD when you can also get a master's? She got her MD from Tulane. She stayed in New Orleans for her residency in Tulane, which is why if you ever go to an ASOPers meeting in New Orleans with her, she'll show you all of the great spots to be able to get a hurricane and some of the delicious food. She did her fellowship at the Bascom Palmer Eye Institute, where she remained for her career. She is a full professor there at the Miami Miller School of Medicine. She's a professor of ophthalmology with an adjunct position in the dermatology department. Of course, we all know she's an ASOPers preceptor. You know, the honors list is incredibly long. Also, a recipient of a Bayless Cosmetic Surgery Award from ASOPers. She's got leadership positions in ASOPers and in women in ophthalmology. And as she's now the incoming president, we're all going to refer to her as Madame President. She's on the editorial boards of numerous journals, just like Guy Massry. She's a key opinion leader with numerous companies of which products we all use. She has an incredibly well-rounded research interest that extends, of course, into aesthetics, but also into cancer and reconstruction and trauma. You know, personally, recently I had the opportunity to spend some real quality time with Wendy when she came to Austin as our keynote speaker for our recent TOC Eye and Face conference. She's a dynamic, bold leader, wonderful speaker. We're really honored to have you here, Wendy. Thank you.
Thanks so much. What a great intro. Thanks so much. So thank you, Debraj and Tanuj, for inviting me to speak. This is such an amazing group of attendees and panelists, and I'm very honored to be here. So thank you for that. Okay, so first of all, it's so unfair that I have to go after Guy Massry because those are some tough shoes to follow. So Guy, great lecture. I love it. But now we're going to focus a little bit on upper eyelid rejuvenation, and I'll talk a little bit about non-surgical options, and then we'll get into a little bit of surgery, not as in-depth as what Guy was doing though. So let's go here. I'll advance this way. These are my financial disclosures, and none of which will have any impact on the talk today. Before we go into ways to rejuvenate the eyelid, I want to talk a little bit about what causes aging of the periocular area. So this is an article looking at facial aging from the inside out. And what happens, as many of us know, is the diameter of the orbital rim increases. So we get that widening space, and then we get some fat atrophy in the periorbital and orbital area. We get stretching of the suspensory ligament, so Lockwood's ligament. So the position of the eyeball itself starts to shift inferiorly, and the eyes start to appear smaller and rounder. The tear troughs become more visible with age. So we get deflation of the soft tissue, that fat atrophy and descent. So we get loss of midface volume, and then attenuation of the zygomatico-cutaneous and orbital malar retaining ligaments, which leads to loss of support and descent of the overlying nasolabial and superficial cheek fat and downward pulling of the skin. We can't forget the temples, because temples age, and temporal volume loss is actually represents the greatest percentage of volume loss of the entire face. And that leads to increased visibility of that temporal crest, as you can see in my patient below. Increased visibility of the vasculature, the lateral orbital rim, and the upper zygomatic arch, which leads to that skeletonized appearance. So I like to use this picture. This is me and my mom. And I use this a lot in my lectures because everyone says I look exactly like my mom. And we are almost exactly 25 years apart. So you could see what happens with aging. And let's focus in on the periocular region. If you see with my mom, you start to see the static lines and wrinkles in the upper face. Definite temporal brow ptosis, medial brow ptosis. Those brows start to separate even, and you have an intercorrugator space that's widening. Definite increase in the superior sulcus, deepening in that superior sulcus with lack of volume. You see that rounder, smaller appearance of the eyes. You definitely see more of the temporal hollowing there, and then some of those lower lid contour defects that lead to the tear trough. So what can we do to rejuvenate these areas? So I'll talk a little bit about topical injectables and energy-based devices before I get into surgery. Topical treatments, tons of eye creams we know are on the market. There's too many to go through. I try to break it down into my patients' most common complaints. So are they complaining of fine wrinkles, dark circles, or puffiness? Those are probably the 3 top complaints I get. For wrinkles, you know, if they're worried about creepiness, at the very least, I think everyone should use a hydrator. So lots of products with nutrients and amino acids. You could get more active ingredients, which will stimulate collagen and elastin, such as retinoids and growth factors. Dark circles are our nemesis. And we know that those are very, very tough to treat. But there are some products with things like vitamin K oxide, which can help absorb some of the blood byproducts. And then tyrosinase inhibitors, which really inhibit the formation of new melanin. And I've listed some of those there. The most commonly or well-known is hydroquinone. And then you can also use those collagen and elastin stimulators to thicken the eyelid skin, such as retinoids and growth factors. Puffiness is tough. People come in complaining of puffiness. Is it inflammation? Is it fat prolapse? Are topicals going to even touch puffiness? Usually not, but there are some anti-inflammatory agents that are included in these eye creams that can be effective to a certain degree, but they're not going to create miracles. What about lash enhancement? We can't forget about lashes because they, matter of fact, increase the aesthetics or improve the aesthetics of the upper lids. There's the one FDA approved prostaglandin analog in the United States. Among others, it just have nutrients and amino acids that can help nurture the lash follicles. But what prostaglandin analogs do is they target the active growth phase of the hair, which is called anagen. And what they do is they increase the percentage of lashes in active growth phase, and they increase the duration of active growth phase so that you get these longer, thicker, darker lashes. Those are my own after 6 weeks of using prostaglandin analogs. Topicals, really quickly, to enhance the aesthetics of the periocular area. I think these are of late hot topics. Brimonidine, which we're all familiar with as a glaucoma drop in low doses, 0.025%. It causes a little bit of vasoconstriction without rebound or tachyphylaxis. So that can enhance the aesthetics. And then oxymetazoline, 0.1%, which can stimulate Mueller's muscle and correct ptosis. So this is my mom again with contact lens related ptosis, and she gets a really nice result with oxymetazoline. But keep it in mind for your average patient, because your average patient, if they use this, will just get a slight more awake appearance, so a little brightening and a little bit of whitening and opening of the eyes too. Okay, switching gears to periocular injectables to shape the eyes. We'll talk about botulinum toxins, and I'll start from the top. The frontalis is what I consider one of the more challenging muscles to inject because it's huge. It's wide, it's bilobed, it's thin, it splits in different patients in different areas. So if you over-inject it, you risk dropping the brows, which definitely affects the aesthetics of the upper lid because you drop the brows, you crowd the orbit, you create secondary dermatochalasis. So be very careful with how much you inject in that frontalis. I never do frontalis without combining it with the corrugators to get that counteractive net lift in that medial brow space. Sometimes you need to avoid frontalis injections altogether. Those are patients with pre-existing dermatochalasis, brow ptosis, blepharoptosis, because those patients really rely on the frontalis, right, to lift those heavy lids away from their line of vision. And then another population to consider are Asian patients. And I put these pictures up. This is like my family album. It's most of my Chinese family. And I've learned the hard way from injecting many of their frontalis. And the problem with injecting the Asian frontalis is we have very unique eyelid anatomy. The Asian eyelid is different from any other ethnic eyelid. And that's because we don't have those attachments from the back of septum and levator to orbicularis that holds that preaponeurotic fat back. So all the fat bill is forward. And as you can see, rather than having this nice contour to the lid, most of our eyelids are very flat and full. I'll give you an example. This is one of my very good friends at work who has horizontal rhytids. And so very early in my career, I injected her rhytids, got rid of them, totally smoothed out her forehead, but left her with a palpebral fissure of about 2. So it's very problematic. So keep that into consideration. The glabellar region, a great area to inject in order to weaken the depressive acts of those corrugator muscles and procerus and open up the periocular space. So you want to inject with the patient upright, head balanced, gloves, and I use my non-dominant hand to pinch up the muscles. So my thumb is going to protect the orbit and my forefinger is going to protect the solution from diffusing into that medial frontalis. Because what happens if you get the solution too high is that you're just going to drop the medial brow here and create the opposite effect, which is an anger look. On the other hand, if you get the solution too low, then you can create toxin-induced ptosis from what's thought to be toxin going into the supratrochlear neurovascular bundle and diffusing back toward that nerve. If you do get toxin-related ptosis, again, you can use oxymetazoline to stimulate those adrenergic receptors in Mueller's muscle. Lateral brow is an important one for non-surgical aesthetics, to combine botulinum toxins with dermal filler underneath the tail of that brow to just give a subtle lift, like you could see here. And that also helps to open up that periocular space, just very subtly. Temples, I told you not to forget about temples. So there are lots of different techniques to injecting the temples. I like to go with my needle perpendicular to the skin all the way down to the periosteum. I aspirate to make sure I'm not one of those deep temporal arteries. And I just inject very slowly. And I lay the product down, yes, underneath the muscle, underneath all the fascial layers. You could actually watch as those tissues elevate over the filler. And I may inject in 1 spot, 2 spots, 3 spots, 4 spots. I just go in the deep end of the swimming pool to try to fill that area, again, very slowly. Other methods for doing this are interfascial injections, subdermal injections. There's lots of different ways to do it, but you could get a really nice result. With men, you can correct a little bit more. With women, you want to leave a little bit of a concavity there, but this can really help to lift the tail of the brow as well. Okay, crow's feet. Well, what we're doing is we're intentionally weakening the tone of the orbicularis oculi muscle, and keep in mind that the orbicularis oculi muscle has 3 components. So we have the pretarsal, the preseptal, and the orbital components. So here's some considerations. Take into consideration patient's age. If we inject the orbital part, are we potentially affecting the muscle from holding back or helping to pump festoons and fluid away? I don't know. It's just a thought. If we inject the preseptal component, are we decreasing that muscle's help to the septum and help to hold that prolapse fat back? Also, I don't know. But I do know that if you get that toxin in the pretarsal component, you are decreasing that tone of the eyelid. So maybe you wouldn't see full-on estropion, but you might see, there's an echo, right? You might feel, and I know this because I've felt it before, just soap and shampoo getting into your eyes in the shower. So it definitely decreases the tone of the eyelid. So be careful about that. Be careful with your patients with pre-existing dry eyes, because that could create extra issues for them. We can use this botulinum toxin to widen the palpebral fissure and open up that that periocular space. So this is a model in Miami who came to see me, bothered by her eyelid asymmetry. So basically, just with very small doses of botulinum toxin to the pretarsal orbicularis. So I used about 2 units in each of these little spots, and you can provide more symmetry. Again, I do warn all my patients that they will feel like they have a little bit of a dry eye. Again, I've tried this on myself, and you definitely can feel more of that air getting in the eye. So I just advise my patients to use a little more artificial tears. I put this in here because I knew Guy was going to focus on surgery of the lower lids. I know this is not on my topic, but I knew people might want to hear about that. So you can get some good improvement with injecting fillers into the tear trough if your patient is, for instance, not a surgical candidate, or they're not ready to have surgery. You can consider this. There are different methods. This is just using a needle, 30 gauge down to the pre-periosteal space. That's what I usually do. I also use cannula quite often. I also have switched more to a 32 gauge needle to decrease the amount of bruising you can get in this area. But I tend to put this product down right on the periosteum, because if not, you can see the product. This is a very unforgiving area to inject. So I always recommend using hyaluronic acid because it's so unforgiving. At least you can erase it, right? We can use hyaluronidase to erase it. This is the most common area that you will have to erase because of either tyndall, lumps and bumps, or issues. So this is your typical tyndall that you can see that bluish hue here. People often think it's a chronic bruise, but it's present for months or years. This is that hypersensitivity reaction, and Guy mentioned this as well. This is a patient who probably 8 months prior to her presenting like this had a tear trough injection, and sure enough, she had a viral illness. So I know Guy mentioned this as well, and we treated her with hyaluronidase and steroids, and gradually she got better and better, but that can be a scary issue. Moving on to superior sulcus. Yes, my mom has a very deep superior sulcus. There's lots of different ways that we can enhance this area with fat grafting or filler. I will just give you a couple words of caution in this area because we know that the orbit is full of lots of vessels, so you certainly don't want to puncture one of those. But we also know that the globe sits closer to the orbital roof. So if you're sticking a needle in that area and your needle goes beyond the orbital rim, just be aware that there's a globe there. Okay, devices, lasers, lights, radio frequency, ultrasound, all can be used on the eyelid proper to rejuvenate the upper and the lower lid region. As far as laser skin resurfacing, there are non-ablative and ablative lasers. The difference being that non-ablative is going to keep your stratum corneum intact, so it's a little less aggressive. Ablative is going to vaporize your epidermis and drive these channels through full thickness of your eyelid. Both work toward the same thing of stimulating collagen, but just ablative is a little bit more aggressive. But you could use any of these on the eyelid proper. You could use them all the way up to the brows, all the way down to the lashes. It's a great alternative to surgery. Some people combine this with their transconj fat redraping or removal, but it's also a great supplement, and really combination therapy is ideal. So here's some examples of patients that I did laser on and who benefited. This patient was bothered by the fine crepiness of her lower lids. This one had a previous upper lid blepharoplasty in the past, but just wanted a little more smoothing, a little more tightening of the upper eyelid skin. This is generalized periocular photoaging. This is a patient, young patient, dark circles, again, our nemesis. It's very hard to treat, but you can carefully use lasers to thicken the tissue and decrease the appearance of dark circles. This one is a patient who had visible upper blepharoplasty incisions. So we used laser on her to blend in the wounds. So this is a video using a non-ablative laser, and this happens to be a rolling handpiece. And you could see that I'm using my non-dominant hand to tauten the tissues, and I can resurface all the way down to the eyelashes, all the way up to the brows. The chromophore is water, so I'm not going to burn those lash follicles. So you can actually roll right over them if you have to. And then I randomize my patterns. I'll do alternating vertical and horizontal passes so that I could get those little spots nicely covered on the entire lid. I use corneal shields because that, number one, protects the eye, but also allows me to go all the way down to the lashes and gives me a more taut surface to apply the laser to. This is ablative laser. So basically going full thickness, you see those tiny little white spots. Well, those are microscopic channels that basically go deep down in the skin. You can program how deep you want those laser spots to go into the skin, and you can change your spot pattern just depending on what area you're on. I turn my handpiece so that I can kind of randomize the pattern again and get full coverage. Oftentimes you'll get some pinpoint bleeding with this one because you go fairly deep. This is, again, ablative laser. This other type is, you'll see this spot on the upper lid. So I use a standoff, and you can see that these spots are much wider, much fatter, but they don't go as deep. And then you have full coverage. So there's no intervening normal space on these. You see, I changed the size of my spot so I could go all the way up to the lashes. You could see that it can singe some of the hairs and the lashes, but it won't ablate the follicles because the chromophore is water. It's not pigment in the hair follicles. So I do full coverage of the eyelids on these. This is an example using a CO2 laser for that patient I showed you with generalized periocular photoaging, which can decrease some of the pigment, tighten some of the skin. Radio frequency can be used. The advantage is you can use radio frequency on any skin type, and it basically works to tighten the tissues. Ultrasound is not going to be used on the eyelid proper, but we could use it, for instance, on the forehead to tighten the tissues on the forehead, give a little brow lift, and open up that periocular space. Okay, light therapy. Light therapy is a spectrum of wavelengths between 400 and 1400 nanometers. And now the chromophore is reds and browns. It's not water. And we use it traditionally for reds and browns of the face. Like you can see here, it can be used for hair removal, vessels, sunspots. But we found out that our dry eye patients were having an improvement. Our ocular rosacea patients were having improvement, probably from obliterating some of these inflammatory vessels, but also heating up the meibomian glands. As far as skin tightening and upper eyelid rejuvenation, you can filter this light to the far infrared spectrum, so 1100 to 1800. Now I'm switching the chromophore to water, and that can help with tightening the skin. And you can see here before and after using skin tightening infrared. Okay, potential complications of devices. You could definitely burn someone, so you have to be careful. You can even create ectropion if you're really aggressive. And then on the right, you can see some pigmentary changes. This is potential complications of lights, which are actually, I find, a little bit more dangerous actually than lasers, because this light therapy is exactly in the retinal hazard region. And remember, the chromophores are reds and browns, which there are tons of inside the eye. So it can be transmitted through all parts of the eye and focused on the retina. We published a study on 3 patients who had ocular damage secondary to light therapy, because it absorbed right into the melanosomes in the iris with photophobia and permanent pupillary changes. So if you're going to do light therapy or laser around the eyes, do not take the goggles off. Make sure you place appropriate goggles and don't reposition. Okay, my last topic, and this is, I'm not going to belabor this because my technique, I don't have a lot to add for you guys. There's not a ton that I do differently in upper eyelid blepharoplasty. It's pretty straightforward. I've got a couple pearls, but if you follow these simple steps, I've used it for years and years and years, just my basic upper lid bleph. And I've had success. I keep getting patients back at least. So I'll warn you, it's not like a groundbreaking new idea for upper lid bleph. You want to make sure you have the right patients. So true dermatochalasis rather than ptosis or brow ptosis. So be able to differentiate that. But many times our patients have a combination of 2 or 3 components. And I will almost always use tape in my clinic and a mirror so that patients realize the difference. So this patient has a little bit of brow ptosis. So I use tape to show her what it could be like doing brow lift, versus on the left side, just taping up that dermatochalasis and showing her what it could be like to remove some of that extra skin just through a blepharoplasty. And again, sometimes we will do both, right? Patient examination, make sure you look at that ocular surface, examine them for dry eyes, if they've had previous or recent corneal surgery, refractive or cataract, or trauma or infections. You'll want to wait until that cornea is well healed before you do a blepharoplasty. Look at the eyelids. This patient came to see me for an upper lid blepharoplasty, but it's important to look and see what's underneath because he had a basal cell carcinoma right near his lid margin. So that, of course, needed to be addressed before a blepharoplasty. If someone has pre-existing leiophthalmos, they're probably not a great candidate for blepharoplasty. And then I learned this, people with lash extensions. So many people have these gnarly lash extensions in my clinic, and I tell them to take them off because I had a blepharoplasty one day not too long ago where my patient didn't take these off and they were getting all in the wound and it was a mess. So tell your patients to take those off. Manage expectations. I almost always look in a mirror with my patients because sometimes what they see is something very different. And I'm going to talk about this for a couple minutes because I think it's really important to recognize if your patient has body dysmorphic disorder before you operate on them. I'll show you that one of my patients, but it's more rampant, right? It's more rampant because people in the media are going extra lengths to change their appearance. And now in the presence of so much social media, I think we have to be extra careful. This is a horrible picture. It's the only one I have of my patient who's from Puerto Rico. And when she was 15, she became obsessed with looking Asian. And she went around the world trying to find doctors who would help her achieve her goal. And she found several who operated on her. And this is her when she came to see me in 2007 with fairly fresh facelift wounds, lots of lateral canthal wounds, and obviously not closing her eyes. She had bad damage to the ocular surface on that left side, but she was still wanting me to do more surgery on her eyelids. Be aware of it. This is excessive concern with an imagined or minimal defect. The preoccupation causes distress and impairs work, social, or personal functioning, and these are concerns that are not caused by other mental disorders. If you decide to operate on these patients, some patients will do well. Some patients do perfectly fine, but 70% of patients are dissatisfied with the result. Patients may escalate their complaints and bear grudges against a physician. And in 80% of cases, the patient will destabilize psychologically and they'll find new defects. What about specific to oculoplastic surgery? We just published this study not too long ago, looking at the prevalence of BDD in an oculoplastic surgery clinic because of the rise in popularity of cosmetic procedures, especially post-COVID pandemic, and in the face of increased use of social media. So we surveyed about 175 subjects with the dysmorphic concern questionnaire. We found that over 9% had BDD, screened positive. I'm not going to say had BDD, they screened positive in my clinic. 67% use social media, and a large percentage of the positive screens reported increased social media use and increased concern about their appearance since the onset of the COVID pandemic. So is BDD a contraindication to surgery? Some surgeons will say absolutely yes. Some will say not necessarily. It's really up to the individual surgeon and the patient to make that decision, but realize it is okay to just say no to some of these patients. Okay, if you're going to do surgery, make sure you're prepared. Make sure you know all of your layers and anatomy in that upper eyelid. I start with a natural lid crease marking. So you see my non-dominant hand tenting up that tissue. And I do this so that I don't leave pretarsal redundant skin. And I just mark the natural lid crease. I usually have the patient look down and start to go into primary gaze to see where that lid folds. I take two non-tooth forceps to gently pinch up that excess skin just so the lashes start to evert, and I make an upper marking. I make sure that I leave enough skin so the patient closes their eyes. So I measure from my upper marking to the brow. That's A, and my lid crease marking is B. And many people will make sure they leave 20 millimeters of tissue there. Maybe I leave 19, I don't know why. Make sure that the patient, this leaving enough tissue is to prevent lag ophthalmos and further brow ptosis, because if you take too much skin, you're going to pull the brow down further. Be careful in patients who have had previous blepharoplasty, because these always, you can leave 30 millimeters and they can end up with lag ophthalmos. So just be careful about that. So here's my skin markings. I make my incisions with old-fashioned cold steel, but of course we can make it with a CO2, or you can make it with your monopolar cautery. I mention this because I don't like to burn the skin edges. And the other thing about cautery during your surgeries, if you're doing them in an ASC, then be careful of this, right? This is a cautery burn from cauterizing in the presence of oxygen. There are three things you need for a cautery fire. One is an oxidizer. So that's usually in the form of a nasal cannula when they're firing oxygen through the nasal cannula. Two is the igniter, which is going to be your cautery. And three is fuel, which lights the drapes on fire, usually caused by either an alcohol-based scrub. So communicate with your anesthetist to make sure that that O2 is turned off. You could do skin only, and I actually do this if patients are on blood thinners and can't come off, if they've got heart disease. But for the most part, I actually remove skin and muscle. I know there's controversy about it. I don't find that their motility of their eyelid or closure changes if I take that off. Either way, I expose that orbital septum. Sometimes I'll remove pre-op and neurotic fat. It just depends on how full they are pre-op. But almost, so if I remove pre-op and neurotic fat, I'm carefully dissecting it off of the underlying aponeurosis, which you could see here in white. And I clamp it carefully, making sure I don't clamp the levator because I don't want to cause ptosis or damage to that levator. I excise it, I cauterize before I release it. You want to make sure you don't over aggressively remove too much fat because you can have asymmetry in the amount that's left in that superior sulcus. The medial fat, we know, and Guy mentioned this, it's different than that pre-aponeurotic fat. It's paler in color, which you could see the difference right here, and realize that there are lots of arterioles that can flow through that medial orbital fat pad. So be careful, because if you clip one of them and you're not aware of it, you can get a retrobulbar hemorrhage. This is from a blepharoplasty, and you could get blindness. Guy also mentioned this, be careful with over aggressive fat removal in that medial space, because you can damage the trochlea. My closure is simple. I take about 3 crease forming bites. So skin, muscle edge, little bite of the septum or levator, and then the upper skin marking, skin edge, just to reform my crease. And I follow it with a running closure. If my patients need a brow lift, then I'll just dissect further up to that superior orbital rim, and I may plicate or do a brow pexy with a proline suture just to position and fixate that temporal brow to the periosteum. Sometimes I combine it with direct temporal brow lifts. Otherwise, brow lifts is a whole nother topic. So I use 7/0 nylon suture. I think it's really a nice suture that's less inflammatory. So my patients come back later. I don't incorporate a lot of the septum or retractor into my closure because I don't want to have eyelid retraction. Post-operatively, I have my patients ice for 2 days, apply antibiotic ointment 3 times a day to the incision, keep the head of the bed elevated. I don't want them to bust a blood vessel afterwards, so I limit their activity. And then I take their sutures out a week later. Other post-op things you could use, homeopathics, sometimes I'll use arnica, bromelain. A lot of my patients will eat a lot of pineapple. Steroids I usually don't use. I do use for my four-lid bleph, so I think it helps. And your goal is to give them a subtle rejuvenation, right? You want to make a difference, but you don't want to change the shape of their eyes. And number one priority is protection of the eyes and maintaining that eyelid closure. So just in summary, we talked about periocular aging using me and my mom. We talked about topical treatments, botulinum toxins, dermal fillers, and devices. And then we talked about blepharoplasty surgery, choosing your appropriate candidate, making sure they have true dermatochlasis and realistic expectations, and foremost, knowing your surgical anatomy. This is me and my mom. I've done tons of non-surgical on her. I haven't yet done surgical, but I'll plug my dad in here because I did do a four-lid bleph on him. So thank you very much for your attention.
Go ahead, Debraj.
That was fantastic. Thank you, Dr. Lee. It was wonderful, and we'll come back to you. I'd like to now spotlight some of the panelists. And truth be told, each one of them is a luminary in their own field and in each of the regions that they practice in. So the first panelist that I'd like to spotlight is Dr. Daniel Ezra. Dan, if you would just introduce yourself and your area of practice in London. And we had 2 specific questions for each panelist. Is there something that resonates with you from these 2 talks? And would you like, is there something that you do differently in your practice? And would you please lead us through that?
Yeah, thanks, Debraj. So my name is Daniel Ezra. I'm based in London at Moorfields Eye Hospital and in private practice in the Harley Street area. Firstly, I'd just like to congratulate both of the speakers. These were outstanding talks. They were really comprehensive, insightful, and evidence-based. And I think particularly Wendy, I think with upper lid treatments, because it's less technically involved, it requires quite a lot of insight. So really congratulations on providing that in your talk. I really enjoyed it. So I've got a couple of points or questions for each of the speakers. I thought the talks were so good. I'm going to actually try and be a little bit more negative and concentrate on the pitfalls, perhaps. The first I would like to highlight is the fact that that fat repositioning in the lower lid can really be overdone sometimes. And Guy, you've really beautifully explained the importance of contour restoration, but I wonder if you could perhaps elaborate a bit more about how the negative vector eye actually changes management, because by doing too much fat repositioning, it can actually skeletonize the lower eyelid a little, and it can actually highlight and focus some of that initial contour of the double bag that you described. And it's probably quite important to just spread the fat out a little bit between the lid and more inferior areas. And the other point I wanted to make as a potential pitfall is for those of you who want to reposition in the pre-periosteal plane, I just want to really emphasize the fact that it's a real danger area in terms of innovation. It's where the recurrent buccal branches of the facial nerve run, and we've known in recent years that that's a really, really important traversing point for those nerves into the lower eyelid orbicularis and the upper lid orbicularis. It is a danger area. You can sometimes see those nerve branches on the underside of the orbicularis flap. So do be very, very careful if you're going to do a pre-periosteal repositioning and dissection in that area. And with regard to the upper eyelid talk, to Wendy's talk, just an observation about the use of Botox in the frontalis muscle. I mean, you've described really well how it's a really tricky area to treat. And I just want to really raise the point about using Botox to sometimes take advantage of this phenomenon of adjacent muscle overactivity. So when Botox is administered to weaken muscle, the adjacent areas can often overact. And that can be used sometimes to model the frontalis, to raise it more laterally. And particularly, there are some who would inject it closer to the hairline, around the superior border of where it's contracting, which can sometimes increase the contractility of the frontalis there. And I was just wondering, what your thoughts were regarding that. And the final issue was regarding tear trough hollows and the use of tear trough fillers. I think it's just important for everyone to appreciate that the narrative coming from the pharma companies about fillers has been known for a long time not to be quite accurate. There's a lot of evidence coming through now that tear trough fillers do not dissolve. In fact, all fillers do not dissolve, as Wendy said. We've got some data coming out shortly showing not just the longevity of the filler in those areas, but also that the volume increases compared to that injected. So if you do an MRI quantification, the volume is actually about 2 to 2.5 times as much as that injected. Which means you can often get it looking fantastic on the table, but they're going to come in later looking swollen. The filler will complex the water, the volume will enlarge, and that can often be a very, very long-lasting effect. And if I have time for just a final question, body dysmorphia, I did read Wendy's paper on it. It was fantastic. The question is, how do you deal with it? Do you confront a patient with it head on? Do you tell them, listen, I think there's a mismatch here between what I'm seeing and what you're experiencing, and I think this may be body dysmorphia. I think there's a real reluctance amongst physicians to do that with patients. I find it's really, really helpful to just tackle that straight on. And I think we know it's there, we know it's a wide-ranging problem, but we've really got to think carefully about how we deal with it, how we approach the patients. And I think we have a tendency to pussyfoot around the issue, to be delicate with the patients. We don't want to have confrontational conversations, but sometimes that's the best way. Thank you.
Great
Should I answer?
comments. You want to go first? Yeah.
Sure. So thank you, Daniel. Let me first, the second question you asked about the recurrent buccal branch. So that's a really good point. So we did the study and compared above and below the periosteum. I did it myself, and I did not have a case occur. But in the audience, what Dr. Ezra is describing is that the zygomatic and buccal branch come together and run along the tear trough, and they innervate the lower lid, the medial part of the upper lid, and the procerus musculature. They have been damaged with external DCRs. It's been reported to be damaged with excising grafted fat in that area. There is no published report that I've seen in the literature of it being damaged with fat transposition on its own. There was a lawsuit in California by a prominent rhinoplasty surgeon who did a closed procedure and fractured the muscle internally, and the bone fragment actually damaged the nerve, and it was permanent. So it can happen. I'm a big proponent of subperiosteal transposition. Those who are against it say it's not a vascular plane, but in my view, you have skin, muscle, periosteum, and bone. And if you're transposing above the periosteum, it's such thin tissue. What are you actually dissecting into? Either the orbicularis or the levator labii. So I think you're right. You can damage it, and it's not my preference in doing it, but it can happen. And those that do it that way should understand that it can happen. The negative vector issue that you're talking about with transposition, I find that, so the talk, I don't like to be a lumper. I tend to be a splitter. If the discussion of the talk is transposition, I think we have to study transposition on its own, results, satisfaction, etc. On a negative vector globe that has a double bubble, when I've transposed fat, because I go transconjunctival, You're just transposing the orbit fat into the hollow. And I haven't seen contours become negative. However, on cases like that, I graft routinely, and I graft with repositioning probably 80% of the time. So in terms of improving the transition of the lid to the cheek, you always have grafting that can help. Let me take it a step further. And again, this is not a negative comment on how people do surgery, but I haven't done a transcutaneous blepharoplasty in 25 years, and I have very, very strong feelings about it. And I think when you're doing negative vector surgery, transposition or otherwise, and you do it transcutaneously, I think you're opening yourself for a lot of room. Why do I feel this way? Because probably the biggest mistake I made in my life was getting very interested in studying eyelid retraction, because I developed a big eyelid retraction practice and then come from all over the world. And it's not a fun practice to have. These are very damaged patients to start with, and it's very hard to fix this problem. But if someone is going to do that procedure, a transcutaneous surgery in a negative vector patient, they're asking for trouble. So, and the reason I feel so strongly against all this is because I see over 100 a year, and from all kinds of surgeons, and it can happen to anyone. And the problem is I see what it does to patients, so I avoid it like the plague because I don't think you gain much more out of it. I wanted to say one last thing you mentioned on the tear trough and fillers, just a personal opinion. I fill about 70% less than I did 5 years ago. I never, under any circumstances, will fill a tear trough on someone that has any eyelid bag. I think it's a bad idea and a bad solution because of what you're saying. I believe fillers never go away. I don't care how much hyaluronase you give. In fact, we have a radiologist in town who now has 3D reconstructions and can actually pick up filler specifically, and it looks blue on the scan. And we have people that have been injected with hyaluronase 4 or 5 times. I think fillers are great in certain scenarios, but it's overdone and done indiscriminately. And I think if someone has an eyelid bag and you give them filler and you follow them long enough and they have repeat injections, they're going to have a problem. In fact, I'm certain of this because I've just been seeing it over the years. So I think people have to be a little more discerning with fillers. They have to understand it never goes away. They have to understand HA gel is bioactive. And be really careful with that, because once you start someone on that realm, they believe that's the answer, and they've had a few good outcomes, and then they want more and more, and you get yourself into some issues because there's a lot of negative to fillers down the road. We were doing it in the beginning without understanding its long-term consequences, and I still think even today there are a lot of surgeons, well-intentioned surgeons, that keep giving filler. And I don't think, I mean, if I would have told you 30 years ago I'm going to put goo in your face, you would have laughed at me. But today it's like this constant trend, and we're seeing more and more problems that are delayed and long-term. We got to be careful about it.
I agree with you. I'm gonna take it from there on this topic, because I completely agree. And I do a ton of fillers, but I can't tell you actually the last time I did a tear trough filler. I actually discourage more of my patients. I say no to more tear trough filler than I say yes to. I agree with you. If they're a surgical candidate, that's the way to go. It does last forever there, and it is very unforgiving. And we are doing a study right now on the dissolution of all the different 21 now plus, because we're going to add the new fillers, and how they respond and how difficult or easy they are to respond to hyaluronidase. And we've done that in vitro. So that's going to come out. But super unforgiving, and it's unpredictable too. It's very unpredictable. The orbital space and the periocular space for fillers, as we can see, can blow up 8 months later for no apparent reason, or after a viral illness. And maybe this was injected with the same thing and didn't blow up. So I think that fillers are very, very scary in that area. And if I have a lower lid bleph patient, I will look at them, and you can tell when they've had filler, and I'll make them dissolve it entirely, no matter how many times it takes before I'll do surgery on them. So that was a filler comment. I'm with you on those, both of you on that. As far as the botulinum toxin in the frontalis, I think that you're absolutely right, Daniel, about the different muscles acting or overacting. And as far as frontalis, alone, we know there's a line of convergence that happens in the frontalis, and we just published on the line of convergence in the platysma as well, where that muscle is a depressor near the hairline, right? It brings the hairline forward and then it raises the brows. So if you inject near the hairline, you'll get a net lift, supposedly, right? Because we're decreasing the depressive acts of the upper frontalis. Whereas if you go too low, you're going to drop the brows. So I think that you're safer if you want to try to brow lift to go superior and above that 2/3, 1/3 line of convergence.
Can I just say
Great.
one last comment, if you have a second, on the filler? So this is something I thought about years ago, and I find it true today, and I see it over and over. Even in people that don't get sick, don't have a flu, don't get a vaccine, don't get teeth cleaning, whatever the case may be. I think when we initially inject filler, the edema and issues we see early on are probably wrong product, wrong location. But people that have done well oftentimes come back, as Wendy said, at 6 to 8 months with swelling. I think that our native hyaluronidase breaks down these fillers in different ways. There could be areas more resistant and those that aren't. So you take something like Restylane, which is 20 mg per ml, its concentration, and all of a sudden you may get areas of it that become 25 mg per ml and areas that may become 18 mg because they're not breaking it down uniformly, and that's been shown. So I think those areas that are hyperconcentrated, because our native hyaluronidase is working on this product, I think they swell. And then the third is the people that come back and are swollen 2-3 years out. And it's this cycle of hyaluronidase refill. I think what happens is when a person comes back to have filling and clinically there's nothing there, there is something there by ultrasound and MR. And when you put new product on old product that's been modified, you have a mishmash and who knows what biochemical characteristics. And I think that's why those people swell a lot. That's why I think I call this an endemic epidemic, because I think it's just indiscriminately injected by so many people. And the last thing is Botox patients, you see them, they stay with you for life usually. Filler patients, I know this because all the filler patients I see have seen 4 or 5 different injectors because they had something, they weren't satisfied, went to someone else. No one really knows their history and what they're injecting, and you're just mixing stuff together. So we just got to be careful with it.
Well, yeah, that and the fact that industry now with FDA approval of their tear trough are widely teaching this injection, where there are so many nuances to this particular location that it becomes a little extra scary, because we're going to see so many more of the issues with it.
And if I may just make perhaps a final point, looking at, we published a series of 1,500 tear trough filler injections, and we did an analysis of independent predictors of problems, and it really is all volume dependent. And if you are going to use it, keep the volume as low as possible. And I think once you get to about beyond the threshold of 0.3 mils, you're going to get problems. If you keep it to about 0.2, 0.3 at maximum, you're less likely to get issues. So just that's the one thing I would say in terms of avoiding these long-term problems, is that keep the volume as low as you can.
Yeah.
Great points. Moving on to spotlight the next panelist. Dr. Dongmei Lee is the immediate ex-president of the Asia Pacific Society of Ophthalmic Plastic and Reconstructive Surgery. She's one of the most renowned oculofacial plastic surgeons from China. Dr. Lee, which parts of the talk did you enjoy the most, and what do you do differently in your practice?
Thank you, Guy and Wendy. I really, really like your wonderful talk. And I tried, there's a lot of the material. I try to catch up, the Wendy's material. It's periocular rejuvenation is a big talk. So I just wonder, like the laser for Asian patient, we have the more pigment. So the laser, how can we consider for the Asian patient is different with the Caucasian? And also the upper lid blepharoplasty also is quite different. I never done the Caucasian patients, so I wonder, how do you think about the different when we remove the fat and we remove excess skin, and also we do the elevator. So it's I think all the different. And for guys talk, I really like your talk, like the low-lid blepharoplasty for the fat reposition. I just do like 5 millimeter. So I wonder how like how deeper you fight goes, and how do you choose the which patient give the deeper to release the tendons and to have the fight reposition. And also for if the patient with the secondary hollow after fat removal, do you like give the fat filler injection or the fat graft? That's my question. It's too many material. Thank you.
Those are great
Alan.
questions, Dr. Lee. Thank you. Laser in Asian patients. Yes, you have to be more careful because of the pigment. You have to be extra careful if you're going to do light therapy. And I know that because I've burned my own skin, because Asians have pigment that you can't see. Many Asian patients seem very fair, but they're not. So for instance, I did IPL on my own face and I had hypopigmented rectangles all over my face for 2 months. So I know, and so for me, light therapy is a little bit harder to deal with in pigmented type 4 skin. Laser, on the other hand, can be very successful in Asian patients. And the one parameter you want to adjust for your more pigmented skin is the density. So your energy levels correspond to the depth of penetration for that laser spot, which is fine. And that you'll choose a higher energy if you're trying to do scarring or deep wrinkles. If you want to do melasma, that's very superficial, so you'll go on a lower energy. But when you choose your density for spot coverage, that's where your risk of hyperpigmentation is going to come in, post-inflammatory hyperpigmentation, and your aggressiveness of your treatment. So just tailor your density if you're going to treat darker skin types. But Asian patients, it's been very successful. The laser that I have is frequently used in Asia with great success. As far as upper lid blepharoplasty in Asians, you are absolutely right. It's a totally different beast. And in Miami, I don't have a ton of Asian patients. You know, I told you I did my dad, I've done my Korean friends. So a smattering of Asian blephs. And I learned a lot from Yoon-Duk Kim, and I watched her do surgery. And I think some of the main differences, because that anatomy and that straight kind of structure of the upper lid in Asian patients, first of all, I have the conversation with my patients. Do they want me to maintain the Asian anatomy with a low lid crease and the fullness? And if they really want to aim toward, let's change it more occidental, give me a lid crease, take out some of the fat, I want more contour, then I model it similar to how I do any blepharoplasty. If they want to maintain the Asian appearance of their eyelid, then I do a very low lid crease. I don't put as many lid crease forming sutures in unless they want a prominent lid crease. And I don't extend my incision out quite as far. I find that for Asian eyelids, I don't come out quite as far as I do for other eyelids. And I don't remove as much fat because I want to maintain that fullness that the Asian eyelids have. So I think those are some of the main differences. I don't pay too much attention to the epicanthal fold. I just make my incision where that natural fit lid goes. And I would say that's the difference. I watched, as far as combining it with ptosis repair, I think that's very effective. And I did watch Yoon-Duk do that as well, just by tacking the levator a bit during the upper lid blepharoplasty. And she had a really unique way of forming a lid crease using 7/0 nylon sutures permanently from that lower skin edge, a little subcuticular bite, and then tacking it down to the tarsal plate, and then closing the wound over that. So those are little tips I picked up from her as well. But I'd love to hear your advice, Dr. Lee, on how to do the perfect Asian blepharoplasty.
Thank you.
Dr. Massry?
Yeah, So something I just Wendy said too is that I won't westernize any eyelids. I'll just refer them out if they want to change their ethnic appearance. I think as you get older in life, you get very selective about what you do, and you want stuff that's really predictable and reproducible in your hands. So, okay, you asked about repositioning and the depth or the length. I'm assuming how far down the rim and releasing tendons. So if you're in the subperiosteal space, you're not releasing any tendons because all the musculature of the lower lid, whether it be the levator labii, the levator anguli ori, originate at the periosteum. And then insert into the upper lip. So if you're subperiosteal, there's nothing to release. If you're preperiosteal, there is. And what Dr. Ezra mentioned, besides putting nerves at risks, you're also potentially putting the origin insertion at risk, although I haven't seen that in patients sent to me. But I do everything subperiosteal, so I don't run into that. But my dissection is all the way to the side of the nose, to Ristow space, the piriform aperture. All I'm trying to do is redrape fat over the rim. And what I find is that if I drape it further down, that's my extension, my dissection's that extensive, is that I get the kind of fill that I want. Some people dissect very limited. Some people only dissect to the nerve and then transpose the fat there. I think in those instances, there's a more chance that the fat pedicle would retract. With a deeper dissection, I haven't had a case retract. I have had nodules, they go away, but I haven't had one retract. And then your last, what was the last? Yeah, on secondary cases, someone's had a standard lower blepharoplasty and they're hollow. How do I manage it? Well, it really depends where the hollow is. Fat grafting into the orbit above the rim, below the lid, I think is a terrible idea. I think it doesn't do very well. Fat grafting along the rim itself can do well. But let's talk about fat grafting. So fat transposition is a native eyelid fat flap. It is a vascularized pedicle of tissue that's being transposed. Again, I transpose subperiosteal. I also wanted to say that if you're transposing on a case that's had trauma, radiation, previous surgery, even though you're subperiosteal, you can take a knife and score the periosteum and get blood, a little bit of bleeding, get some blood supply into the flap if you're worried about ischemic issues. But the reason I bring this up is a flap is different than a graft. A flap is a vascularized pedicle. A graft, we harvest fat, and it's a total discussion. It's a totally different talk. We harvest it from somewhere, process it, re-injected, and it becomes ischemic in that interim. And how much of that fat is going to be accepted on a secondary case? And that is unpredictable. And I don't care what anyone tells you. Doesn't matter what anyone, the people that graft fat most in the country, a graft is a graft, a flap is a flap, and there's a difference, and fat grafting is unpredictable. Let me tell you the biggest proof of that. You find me one paper that has studied isolated fat grafting around the eyelids with results. There's a reason no one's done it, because I don't think anyone in their heart of heart really believes how predictable it is. Fat grafting is typically done as an adjunct with transposition, with muscle plication, with skin excision, with laser, other things that improve the appearance. So I think fat grafting is unpredictable. If they have a hollow after primary lower blepharoplasty, I think grafting the rim is realistic. I tell patients I have no idea how much will survive. I don't tell them 50%, I tell them no idea. But if their hollow is in the orbit, fat grafting the orbit is not a great procedure. You could put a dermis fat graft, they're unpredictable too. That's a tough thing to fix.
Thank you.
Okay, thank you.
We'll now spotlight the next panelist. Dr. Jocelyn Kohn has been a leader from Chile as well as for Sopanop. And Josie, do you have anything to comment on the talks today? And do you have any questions and anything to tell our audience?
Thank you so much for having me here. It's such an honor and pleasure. And of course, I have questions. I mean, this has been such beautiful lectures, and I think we've all learned so much. And all this discussion, especially around fillers and toxins and other procedures we're doing. And I was really inspired by Wendy with I'm starting to do surgery on the patients. I did injections 10 years ago. So these patients that maybe wanted surgery 10 years ago and they had Botox, I'm giving them, I'm doing blepharoplasty on them. And I look at the pictures and they're very happy, but I look at them and they don't really look as they looked 10 years ago. And in my head, I wanted to rejuvenate them, right? Because in our essence as oculoplastic surgeons, I truly believe I want to be more of a restorative surgeon more than a transformative surgeon, because I learned that from Guy and Massry, and I really want to be true to that principle. And I think that's what patients should have. So I wanted your thoughts about how do you think people are aging because of how now they're having all these procedures and Botox around their eyes, and their way of communicating and expression over time. And then I have this other question about the filler in the lower eyelid, producing congestion and producing orbital swelling, affecting the upper eyelid, because I'm having patients coming in way earlier because of puffy upper eyelid now, and they want surgery. And I don't think giving them upper blepharoplasty is the proper answer. And then for Dr. Massry, I'm a big fan of lower eyelid transposition. I truly believe that's the goal of restore volume is definitely the way to go. And I wanted to ask you, when you have these patients with filler, what would be your technique of an election? Would you transpose these patients, or would you rather resect and graft? And if you have any thoughts on protocol, whether to dissolve before, give them the mycophenolate, I think that's a great idea. I have to try it. Antibiotics, whatever you do there, and how much time before. I think there's a lot of discussion about that, and it would be great to know. So yeah, thank you.
Oh, those are great and tough questions, Dr. Khan. What happens over time with repeated botulinum toxin injections specifically? Because I think we're all going to see and deal with these patients. So is there a significant amount of muscle atrophy after time with these patients? You know, we know we can do facial shaping with masseters, so we know we can get some decrease in the mass of the muscles. We use it for the prominent pretarsal in patients who don't like that jelly roll. So let's assume that there's some muscle atrophy. People often wonder, if we repeatedly inject the crow's feet area, are we going to get more temporal hollowing, right? And so I think we have to pay attention to that. And for instance, like my own mom, who her inner corrugator distance is huge now. And I think that's partially from maybe overplucking of her brows, but also, you know, she's got medial and temporal brow ptosis, but those brows have just split apart so far. When we're rejuvenating patients 10, 15, 20 years later, I think we do keep that into consideration. We can't build up that muscle again. But if we do have more temporal wasting, do we graft there? Do we fill there? Do we decrease the amount of toxin we do, right? Because if they start to look abnormal, then maybe we myomodulate with fillers instead of toxins if we think that the botulinum toxins are causing too much muscle weakness. Are they having dry eyes and we don't want to create more lid laxity? So there are certain situations where I think we have to evaluate and say, hey, let's slow down on those botulinum toxins because people are starting to look a little abnormal, and decide what's the best natural way to rejuvenate them. Is it surgically? Is it with their own body's fat and fat grafting or transferring? Or can we use filler effectively to give them volume, or things like polyolactic acid or the biostimulator injections that can help and restore more collagen? So I think that people who have done conservative but consistent amounts of these biostimulators, those can look very natural because that's your own body's collagen. So I think that's a tricky one, but definitely a consideration. And then what was your second question for me? Is
The puffy upper
the upper, the edema. I'm not really sure. If you're asking if the lower face botulinum toxins are affecting edema in the upper lids.
No, the filler. If the lower eyelid filler or overall filler, because of eyelid swelling and the orbital congestion, are you seeing upper eyelid?
I'm not seeing,
yeah.
I actually don't see that often from lower face filler. I definitely have seen complications of temple filler that goes through the zygomaticotemporal foramen straight into the orbit, and filler ends up right behind the lacrimal gland, causing ptosis and chronic eyelid edema for sure. And I just had to go in with hyaluronidase behind the lacrimal gland and absorb it. So there is a little foramen that goes straight into the orbit. So when you're injecting in these different areas, it's essential that you know your anatomy and where that can end up, of course. Can you get upper eyelid edema if you hit in that infraorbital region? Again, what Guy mentioned, and with the anatomy, it has to travel pretty far, but I guess theoretically you could. The biggest area would be temple, probably, and in your forehead. Forehead is the most dangerous area for blindness, as we know. But other than that, so that's the one case where I definitely saw upper eyelid edema after filler, facial filler.
That's really interesting. So I think filler is a gel. It could migrate for anywhere, and we can never say never in medicine, but this stuff does migrate and it doesn't go away. And I've seen every possible, I mean, in LA, at least, I'm sure everywhere. It's when I see patients, it's not, have you had filler? It's how many times have you had filler?
Yeah.
Even and they're starting here at 18, 20, 22, 23.
Yep.
So the big question is, why are we injecting people so young? And it's just kind of a trend. Second, you asked a question, I think, how we age. I just wanted to, so if you take someone who you see at 35 and then you follow them over time, you've done nothing on them, no injections, nothing. And you see them at 45, I don't think that a blepharoplasty is going to restore them to 35 because they have natural aging. How much of that is altered by neurotoxin? That I'm not convinced of. How much of it is altered by filler, I'm completely convinced of. And that's why I also want to bring up something about fat grafting. When filler first, in 2003, when it was first improved and we injected people, we had no idea what the long-term effects of filler were. We're finding it out now. It's 20 years later when we're finding out so much information. Fat grafting is great, but I think it's way overdone. In fact, I know it's overdone because people are putting large amounts in the face. Just forget the periocular region. We know that premenopausal women, there are those who won't inject a premenopausal woman because with the hormonal changes of menopause, who knows what happens to it. I think around the eyes, it's safe, it's small amounts, but people that put 40 cc's in the face, we've seen these fat faces. So what I'm saying is we have no idea what we're doing to patients until we have an idea what we're doing to patients years later, because the story always unfolds over time. It's kind of my thought on that. I think you asked a question about filler and surgery. I always dissolve before, but I have a protocol for patients that have had filler anywhere on their face, but specifically the mid-face temples or lower lids. I tell them beforehand, I expect a long, protracted recovery. And if they are even, I won't even touch them because I'm telling you, filler is the bane of lower eyelid surgery. It makes everything unpredictable. I don't believe there's any way to predict it. And when Daniel said is right, volume is key. But the majority of people I've seen have had filler many, many times. And the majority of them, it's an example. I have a dermatologist who's coming in from the East Coast who's had filler, and she has mild bags and hollows. And what I told her was, I need to see you in person, and I need to dissolve you in person. I don't even trust other people to do it anymore. Because the fact of the matter is, I have no idea what I'm treating when they've had filler put there. Mycophenolate I only use for inflammatory situations. If they're not inflamed, I don't. I would read about it beforehand.
It's 9 o'clock.
Okay. And always check their white counts.
So we are running a little over. There are still 260 people watching, so I guess they are still interested. Dr. Qingin Wu, we'll bring her in now. She's the incumbent and current president of the Asia Pacific Society of Ophthalmic, Plastic and Reconstructive Surgery. She's from Korea, and it's past midnight, and she looks fresh as a daisy. It's over to you, madam.
Thank you for your kind introduction. I like the Dr. Massry's step-by-step lecture. Could you share the reason of your preference of subperiosteal approach? Because in my practice, I like the supraperiosteal approach very much because it's easier and then no need to dissect deeply or something. And then for the chemosis, is there any preventive measure for the chemosis? And then usually for the chemotic patient, I usually use the subconjunctival radiofrequency Elman cautery, even for the early post-op period, like 1 or 2 months, because patients are very unhappy with that. So for 2 questions, what's your opinion?
Okay, so just writing those down. So sub versus supraperiosteal. I'm an anatomic surgeon, and the subperiosteal plane is a clean plane. You're above muscle, you're above nerves. It is really, really hard to hurt something. Now, I've studied it and compared the 2 approaches. I didn't have any complications from supraperiosteal repositioning. But those that do it, I always ask the same question. When you're dissecting above the periosteum, what are you cutting through? You're either cutting orbicularis, levator labii. They're stuck together like glue. So in my mind, it is easier for sure. But in my mind, if someone were to ask me, you're going to traumatize neuromuscular tissue or you're not, what's your preference? And that's why I've done it this way. And it's just become so second nature to me. But the outcomes are not different, but I have not done a supraperiosteal repositioning since I wrote that paper. It's been 10 years. So that's why. But if someone, by the way, for everyone audience who's listening, if you get a good result doing something and in your hand it works, don't change it because it works. What was the second question you asked? Oh, chemosis. Yeah. So the easiest thing I have found that reduces chemosis is reducing the aperture and creating compression that's non-invasive. So I usually take a 5-0 chromic suture from gray line to gray line laterally and sew it together. On rare occasions, patients become claustrophobic. I tell them I'm going to do that. If they want me not do it, I won't. And when I said I treat chemosis usually with drops, massage, that little suture, but if it persists beyond a month to 6 weeks, I do similar to what you do radiofrequency subconjunctival. I just give a bleb of lidocaine under the conjunctiva and take a handheld cautery, and like you're doing PRP in the retina, I just dot it, and it literally goes away within a day or 2. It's the same thing. What we're doing is the same thing, just a different way of doing it.
Is there any preventive measure you say about the therapeutic measure for the chemosis? But I think there is some lymphatic drainages, site, and then depth, and then location. But I don't know much about that kind of information from the literature or something. So could you share the specific location or specific depth of the lymphatic structures?
So
If we know the site of the lymphatic drainage system, then we can avoid the chemosis occurrence after the lower blood.
So I've thought about this. I don't think it's avoidable. Transcutaneously is totally different because transcutaneous, you're disrupting a lot of structures. You're disrupting the muscle contractile effect, which has something to do with drainage. On most transcutaneous procedures, the canthal suspension is done as a preventative measure of eyelid retraction, which is a totally different talk. I don't think it makes that much of a difference, but it's a totally different talk. but you're damaging structures that will increase the incidence of chemosis significantly. With transconjunctival surgery, in the majority of cases, it's a transconjunctival incision. I'm not sure what you can do to the incision except for make it higher to reduce the incidence of chemosis. But the lymphatic strain through the canthus, out the ear, behind the ear, and into the neck. If you're disrupting the canthus, if you don't disrupt the canthus, it'll be more preventative. So if you do procedures that are canthal preserving, then you'll have less of it. But the incidence in my hands is about 8%. So 8 out of every 100 patients have an amount of it. And about 1 or 2 of those, it'll persist beyond a month. I tell people that beforehand. Everything I do, I'm a total nerd, a complete nerd. Everything I've done, I have studied and have percentages, and I tell patients. This is when I do lower lid retraction surgery. This is really fast, just a digression. When I do lower lid retraction surgery, I tell patients, if I show you result to doctors, 90% of them are going to think it's a great result, but only 40 to 50% of patients are totally happy with it for a variety of reasons. I just let them know everything beforehand so that they can make decisions. And that's why I study statistics on everything.
Thank you. Time to get our next panelist in, Dr. Kasturi Bhattacharjee. And Dr. Kasturi is the incoming president of the APSOPRS and quite a diva at many things that she does. Dr. Kasturi, what I'm going to do is I'm also going to get some audience questions in. I wanted to know, this is from Dr. Dolly Rai. I know that you do a lot of non-surgical stuff as well. We've heard a lot of voices which tell us that fillers may not necessarily be good in the long run. Are there certain ways that you use or discern in whom to use surgery versus non-surgical treatments for your patients?
Thank you, Dave. And let me congratulate both the speakers for the outstanding presentation and sincere appreciation of the expertise of both of you. So that's a very wonderful question, like especially in Indian scenario, like we have got 3 major indications. Like first is what we feel that in India, we have good amount of your pigmentation, periocular pigmentation. We have real prominent trough, the tear trough, and also the fat prolapse. Even at a very young age, we get the fat prolapse, and these are the patients who don't want surgery. So what I feel that when you use this dermal filler, we give them 3 benefits. It really takes care of the pigmentation, not because it decreases the pigmentation, but what they do, it decreases the shadowing effect. So that it really gives a good, decrease in the color, the pigmentation. Secondly, the trough, which I have already mentioned, we really have, and I really believe that when we mention the prominent tear trough, this is basically a separation of the palpable part of the orbicularis muscle from the orbital part of the orbicularis muscle. So if you can really fill up this portion where there's a separation of the muscle, which really gives a very prominent trough, it really gives a good result. And thirdly, it conceals the orbital fat in many situations. And I have seen wonderful presentation by Dr. Wendy Lee, like in many cases it does. I also agree to Dr. Guy that he mentioned that filler doesn't go off. Like I have some of the patients where I do routinely the ultrasound, even for the last 5-6 years, I have seen that filler is persisting, it does not go off. There are many case reports of migration of the filler, but I feel that in many situations, the low G prime fillers does help in many situations when they don't want to go for the surgery, and especially when you have nothing to do for the pigmentation. Once the shadowing effect is being decreased, the pigmentation that we see in India is being much taken care of. And secondly, what I want to ask Dr. Guy, I have a very 2 specific question for Dr. Guy and also Dr. Wendy. Dr. Guy, you have mentioned that you're doing pre-periosteal transpositioning of the pedicle flap, and I have been also doing, but I prefer doing pre-periosteal. I do supra-periosteal, and I have been doing it for the last 15-16 years, and I feel the results are pretty good. Like one point that I want to ask you, like when we do a too tight, like when we keep the pedicles too tight, we know there are lumps. So how do we assess on the table the tightness of the fat pedicles, especially when the patients are in supine position? So do you have any way of assessing that how tight is the fat pedicle in order to prevent the lumps? Second question I'd like to ask you, in situation of those type of stator blepharon, where there's a lateral fat ped, having spillage into the recess of the ace nerve. So how do you manage those type of lateral fat, but when in the ace nerves, when the recess, the fat is being spillage? And my two question to my friend, Dr. Wendy, is number one, in case of deep superior sulcus, especially when they have the A-frame deformity, you inject dermal filler, but do you inject pre-periosteal or the pre-septal? I do lots of pre-septal, so I'd like to hear from you whether you prefer a pre-periosteal. And the next question to Dr. Wendy is, have you tried that triple L, like LLT therapy, that low light laser therapy, especially in case of post-blepharoplasty or the periocular edema, to decrease the edema, because we know that it enhances the lymphatics and also decreases the inflammation. And the next question to both of you, any experience with the biostimulators? Like, because we know that they promote lots of the body's natural collagen, like any experience with the PLLA or the calcium hydroxyapatite, like especially in cases of periorbital rejuvenation?
So thank you for your questions. They were great. So the first one about, wait, remind me again, the first question was the pedicle, remind me again?
The tightness of the pedicle on the table, because they're in supine.
That's a great question. So the reason I use that long piece of telfa is because what I learned over time, when I tie it, I don't want the telfa to buckle at all. If you tie it flat and the telfa is not buckling, if it buckles, you've tied it too tight. If it's not flat, you've tied it too loose. I just learned this over time from trial and error. But if you do 2 throws and it's completely flat, you can have the assistant pinch the knot, or you don't have to. And as long as the telfa is not buckling, that's my sign that it works. That works for me. The second question I couldn't understand. It was something about transposing the pedicle. I didn't quite understand.
Lateral fat.
Something like the ace-nerve triangle, where sometimes the lateral fat bed is a spillage into the ace-nerve cavity. So do you see those type of patients? Especially you do transposition of only the medial and the lateral, like the central, not the lateral. So when there's a spillage laterally, so how do you manage those type of fat? We know that there's a ace-nerve cavity space here.
I transpose lateral fat. Yeah, as I said in the talk, I transpose lateral fat all the time. The difference is that I'm 100% convinced in my mind that the subperiosteal plane is the most appropriate plane and safest for the patient here. But laterally, because the tissue is so thick, I go right above the periosteum. It's a more vascular plane, and I transpose it supraperiosteally, and I can fixate it internally or externally. And if there's a gap between the 2 fat pads, I'll put an internal suture and bring them together.
Thank you. And Dr. Lee, Dr. Wendy?
Yeah. And I do that too, Guy, supraperiosteal on the lateral, because I feel like that helps fill that gap you're talking about. Filler to the superior sulcus is really tough. I don't often do it, to be honest with you. If I do pre-periosteal. I don't inject filler pre-septal, because I feel like the risk of edema is very high. Of course, depending on which product you use, right? I think you have to use a very, I'll say light product, maybe less concentrated, less cross-linked, but I don't do pre-septal, but I'm happy to hear that you get great results with that. As far as the low-level laser therapy for post-op edema you're talking about, I don't use that. So I can't even answer any experience because I don't use low-level laser.
The IPL, right? So you're using
the IPL.
Yeah, it comes with that. It have the face, setting, and also the dry eye setting. So there it has an IPL mask where you can use the LLT for the post-blepharoplasty edema, and it really gives very good result. Like patients, they come and tell me, "I want this." Like after having.
Wow, yeah, I don't use it, and I don't use. A lot of the dermatologists will use different devices for bruising after fillers. I don't use that for, patients are going to have bruising and swelling, and it's just about setting their expectations and using different methods post-op to help them get through that. Biostimulators, yes, I use. So I use polylactic acid. I'll use a little bit of calcium hydroxyapatite. I don't use it around the eyes though. I won't use those products. because I know, they've reformulated and changed the way we reconstitute polylactic acid to decrease nodule formation, because at the very beginning, the first generation, it was associated with nodules around the face. But now they've changed that a little bit, and we reconstitute it very specifically, and we have our patients massage like crazy for the first 5 days to prevent that. Even with that, I won't inject that around the periocular space. I would consider doing it around the temples, but even that I don't do. I have done calcium hydroxyapatite in the temples. Now most of my biostims are in the face, all over the face. Yeah.
So I agree with her. Let me just also wanted to mention this comment on hybrid fillers that people are using. I think this is one of the things that we're going to find out years later. We made a big oopsie and a big mistake. I think when you mix a gel filler with one of these semi-permanent, permanent fillers, I think the gel encapsulates the particles, and as it dissolves, you're going to have a lot of late and delayed issues. I don't think that's been looked at really very well, and the long-term outcomes on the few reports that have come out in publication are very short outcomes. By the way, in the eyelid literature, there was a cumulative review of all the papers ever written on eyelid surgery. Do you know what the average follow-up is, as a guess? And this is what we base what we do on. On average, it's as low as 12, the average. It wasn't in between, it's 12 to 18 months. So everything we do is based on 12 to 18 month follow-up, which I think it's just a little hard to make long-term decisions on these things when our follow-up is only 12 to 18 months.
Thank you. I'd like to bring in Professor Dr. Reynaldo Havate now. He's he's the founding president of the Asia Pacific Society of Ophthalmic Plastic and Reconstructive Surgery. Dr. Havate is one of the most renowned oculofacial plastic surgeons in Manila and Philippines. And Dr. Havate, over to you. I'd like to bring in an audience question for you, sir. I did hear Dr. Massry's comments on ciliary or skin-related lower eyelid blepharoplasty. Do you do any skin-related lower eyelid blepharoplasty, or is it completely transcutaneous or transconjunctival in your practice? And are there specific instances where you'd like to try the skin versus the conjunctival approach? Would you please unmute yourself, sir?
Okay.
Yes, sir.
Thank you
Yes.
very much, Deborah, for having me here. Good morning or good evening, wherever you are. Well, as far as my practice is concerned, actually, I've adopted I also do the technique of Guy. However, I've adopted the technique of transcutaneous blepharoplasty, which is actually, to my mind, will address the elements of aging layer by layer. Actually, I do lower lid blepharoplasty with some sort of mini-mid facelift, wherein this will allow the blending of the lid cheek junction. I do, of course, preserve the pretarsal orbicularis muscle, and then 5 to 6 millimeter below the lash line, and then I transect the preseptal orbicularis muscle, go down deep into the arcus marginalis, and from there, I do some sort of septal reset. Of course, I do some septal, what I call small septal windows in order to herniate some fat, and of course, cuts some of it. And then after that, I do lateral cantopexy, lateral orbicular suspension, and of course, a minimal amount of skin excision. And that's how I approach my lower lid blepharoplasty. Of course, not to forget the release of the orbital retaining ligaments. And I've had good results with my transcutaneous blepharoplasty. Yeah, but of course, I do, appreciate the technique of Guy Massry. He's really an excellent surgeon, and for giving us an excellent talk, and also with Wendy Lee. But I have questions for Wendy Lee when I do, because I think the objectives of upper blepharoplasty are, most of my patients would want a pretarsal platform of the lid show, aside from volume, fullness of the volume, and of course, correction of lid height and balance symmetry. Now, in most of my patients, I do get, a puffy, bulging eyes with a low brow, but these patients do not want to have a brow lift. I would like to ask Wendy, what do you do with these patients? How do you approach upper blepharoplasty in this patient? And I also get lots of patients with low brow and at the same time with lateral hooding. How will you approach or deal with these patients?
Great question. I have many patients like that as well who don't want their brows touched because they're worried that that's going to change their appearance too much. In that case, I'll let them know that I could do a conservative blepharoplasty and take some of that weight away. But they're still absolutely going to have a hood of tissue there because they need that to close their eyes. If not, they'll have lag ophthalmos, or I'll just chase my tail and pull their brow down further. And I'd say one of the biggest complaints after something like this is that lateral hooding after. So it's all about setting the patient's expectations. I'll always use a mirror and show them if the tail of their brow is low, then I'll either say I can do a brow pexy internally from my upper blepharoplasty wound, no extra incision. I'll just take a Prolene suture and tack it to the periosteum in order to fixate it so it doesn't drag further and hopefully get some of that lateral hooding. I'll tell them they will have lateral hooding if I don't raise that brow. If they're open to it, I think that aesthetically you can get a pleasing result with a small direct temporal brow lift with the little incision above the brow hairs, because the temporal direct heals very nicely. But if they don't want that, I'll try to talk them into a pexy. And if they don't want that, then I will just set their expectations that they're still going to have hooding. And the best I could do is a limited blepharoplasty to take some of that skin away. As far as, creating more of a tarsal platform show, then while maintaining fullness, is that what you were talking about? Maybe not taking too much fat away, but creating a nice, strong tarsal platform show, then I think that that's where those lid crease forming sutures come into play. And even doing extra ones, for instance, in the case of an Asian patient, with those deeper buried permanent 7/0 nylon sutures before you run the suture.
Yeah. Yeah. Actually, I also do, for patients with low brow, and of course, those with patients with lateral hooding, what I've done that internal brow pexy, but sometimes, it doesn't work. So what I've done for these patients is actually, what I do is, I do try to remove the superior half of the orbicularis. And then at the same time, I do what I call a suturing of the upper septum, and then attach it to the deep orbicularis in the upper incision, and then also attach it to the inferior incision, a deep orbicularis suture. So in that way, I'm able to, address the problem of this lateral hooding, and also, the not only the lateral hooding, but of course the low brow on this patient. Now, on the other hand, addressing the problem of, for example, a puppy bulging eyes with low brow, what I've done with it is that in the same manner, I do what I call, of course, I remove the superior half of the orbicularis, but at the same time, what I do is I do septal thermoplasty in order to fibrose the septum, and of course some of the fat. And this is how I address this problem. Yeah.
Can I interject something? I think it's important for the audience.
Yes.
This lateral hooding and brow ptosis, why are patients so freaking scared of brow lifts? That's the real question we should ask, because we're devising surgeries that are non-anatomic, really, that may not even work to try to fix a problem. The reason patients are so scared of the term brow lift, and it's the reason I don't even use that word anymore, is traditional lifts were lifts like this. There's nowhere on the face where things are lifted directly vertically. Facelifts are this way, brow lifts should be this way, but traditional surgeries led to widening of the inner brow distance and an elevated medial brow, and they look surprised. How do I know that? They tell me. Now, 90% of patients that I see with eyelid hooding present saying, I want a blepharoplasty. I want my hoods taken away. And 90% of them need something done to the brow. So I use the term brow recontour, brow reset, or temple lift. I don't even use brow lift, and then I explain to them what it is. And I think that that helps a lot in their understanding and reduces the fear of it.
What about your brassiere technique of the
For what?
brassiere technique? Your technique of doing the
Brassiere
yeah.
brow fat suspension suture is really a volumizing procedure more than a lifting procedure. And I just secure the orbicularis at the upper edge to the arcus. You can include the lower orbicularis. And what it does is it elevates and anteriorly projects the brow fat pad. But I don't find that it elevates the brow too much. But it does help on improving the appearance of the brow lid junction laterally.
In the interest of time, I'd like to move on to the last panelist, please. Dr. Yunia Irawati, and she's the current president of the Indonesian Society of Ophthalmic Plastics and Reconstructive Surgery and the vice president of the APSOPRS and a close friend. So Dr. Yunia, do you have any questions, any comments, anything to say to the speakers or to the audience?
Okay. Thank you once again, Deborah, for involving me in the wonderful meeting. And thank you, Miss Wendy, to sharing your experience. I think it's in blepharoplasty, not only in the oculoplasty region, but I think plastic surgeon and then the aesthetic doctor, even the medical doctor doing the blepharoplasty in our country. And I think so many questions from the all panelists before, but maybe in your experience, some our patient doesn't want to change the eyelid crease, but they want to do the resection for the skin in the suprabrow incision. Did you have an experience with dealing with incision actions and skin in the suprabrow incision? And for the complication, like Dr. Professor Wu said, there's some case with the chemosis, some things patient is almost doesn't confidence with that condition. After several times that we give it a conservative treatment like compress and then doing the lid massage and steroid orally or topically, sometimes after 2 months, if there is no improvement, but we notice the preoperative before we look there was a conjunctival callosis in the patient. Did you have an experience in patient with the conjunctival callosis that have a chemosis after the blepharoplasty in the lower eyelid blepharoplasty? Did you what did you suggest for the correction the chemosis? And the third question, maybe some patient when we do the examination preoperatively doesn't have fat prominent, but actually they have pretarsal orbicularis hypertrophy. What did you suggest the patient? Thank you.
Great. So I think, correct me if I'm wrong, your first question was about a suprabrow incision, not the subbrow incision for upper lid blep. You're not referring to the subbrow
Yes.
incision. Some people do subbrow,
yes.
right? So
Yes.
I actually don't do that. I know that I believe Bob Goldberg does. Guy, you might do that. I don't do subbrow incisions for my upper lid blephs. So I can't really comment on that. I'll defer if Guy does it. I don't know if he does. What was there another question related to that? The upper lid? surgery?
Yes.
No?
No. I think my question in the conjunctival classes when the
Oh, okay.
patient did yes.
Pre-existing condylosis.
Yeah.
Guy, you want to?
For subbrow blepharoplasty, I have seen many that have come to see me. I don't do the surgery. I think there's a lot of pros and cons to it. People do it. They do it with plicating the brow, plicating the orbicularis, etc. But I don't do the surgery. I don't have the patient population here that wants it, so I can't comment intelligently on that. Conjunctivochalasis before lower blepharoplasty would be a very rare event for me, but I can resect conj or cauterize conj if I need to in redundant areas before doing the surgery. And then you asked about pretarsal hypertrophy in the lower lid. So usually, because I'm not, I'll usually treat it with Botox post-operatively. I don't cut out the muscle. I don't make an incision in the skin for it, but I'll treat it, I'll neuromodulate it after surgery once they've healed.
Same.
Okay. Thank you.
Thank you.
Well,
So it's been
again,
a great time to hand over to Tanuj right now.
well, I just want to thank everybody. I know we've gone over a little bit, but on the other hand, this conversation has been absolutely fascinating and enjoyable, you know, I'm sure for all of the attendees, but certainly for me as well. I want to thank Dr. Massry and Dr. Lee for being our keynote speakers. Your insights and what you've shared today with us is basically a gift to the world. We really thank you very much. And to all our panelists for bringing in perspectives from Asia and the UK and South America. We thank you all. Everybody has unique perspectives. You know, the one thing that's wonderful about medicine and our specialty is that, you know, if we're open to learning from each other, we can open our own minds to new ways to take care of our own patients, which is really the ultimate goal of why we all became physicians. So with that note, once again, just want to thank you all. Have a wonderful evening or rest of your day wherever you are. And please stay tuned to our channel at Global Cosmetic Surge on Instagram. We'll be having more events like this in the future. Thank you once again. Goodbye.
Bye-bye.
Thank you.
Thank you.
Thank you and congratulations. It's an amazing meeting and we learned so many things, so many learning points.
So kind of
Thank you,
you.
Kasturi. Yeah. Look forward to
We
seeing you in
deeply
person sometime.
appreciate you.
Yeah.
Thank you.
Okay. Thank you, everyone.
Bye.
Thank you.
Thank you.
Thank you.
Thank you,
Thanks.
everyone.